Okay, so I'm going to welcome our first speaker for today, and that's Tiffany Taft, as Joan was mentioning. Tiffany's an old colleague of mine, actually, from when I was at Northwestern, so it was great to see her. She's an associate professor of medicine and is an expert at psychological issues in GI diseases, and today she's going to speak to us on psychosocial issues related to intestinal failure. Tiffany?
Good morning, everyone. Thank you for coming in so early to talk about, listen to me talk about this topic today. Thank you to the Oley Foundation for having me speak at the conference. Psychosocial issues are definitely an important part of all chronic illnesses, and I think, highlighting them, bringing them into the conversation is a really important part of patient care. So we want to make sure that we give it the time, that it is much needed. Okay, there's my disclosures. I do own a private practice here in Chicago where myself and my fellow clinicians treat patients with mostly chronic digestive diseases, but we see across the spectrum, and I do have some patients on home nutrition as well. So this is a very broad topic, and when I get asked to speak about psychosocial issues as a whole in about 20 minutes, I kind of chuckle to myself because I could do a talk on every single bullet point up here in more than 20 minutes, but I will do my best to do this justice. So there are a bunch of things that we know that are part of this topic that I want to try and highlight the best I can today. So I'm going to go over what the research says, what we as professionals, psychologists, physicians, et cetera, are doing about it, and then what you, patients and caregivers, can try to do on your own. So I found this quote in a paper in 1979. So I was 4 years old when this was published, and it really gets at that we have to address the psychosocial issues related to home nutrition, TPN, et cetera. And they put it nicely. If we're going to make this a means to improve quality of life in patients, we need to really make sure we're addressing the psychological and social impacts as well. So this was back in 1979. So what does the research say? So these are the areas that we tend to see psychosocial impact, which again is a very broad term. So we do see neurocognitive problems that is related to the lack of nutrition, vitamins and minerals, being in balance, et cetera. We actually do see impacts on the brain, including things like executive function, which is a fancy term for problem solving. It's the front part of your brain, your personality, all these things that making higher order decisions that we as human beings need to do on a regular basis. That's what executive functioning is. Also memory, concentration, things like that can be affected as well. Also, health-related quality of life, loss of autonomy, dependence on, the nutrition, the time required, the impacts on being able to go out, being able to travel, being able to work. Those all fall under health-related quality of life. And then I really like this statement on the importance of food, and feeding and nutrition extends way beyond our body's physiological needs, right? At least here in the United States, food is a very social thing, and everything seems to be around getting together with friends, going for a drink, having something to eat, and every patient that I see that is impacted by food, whether it is to the point of needing home nutrition or just having a restricted diet, this comes up all the time. I can't go out with my friends because if I go to the restaurant, I'm going to draw a lot of unwanted attention to myself, and I really don't want that in my life, and learning how to navigate that is part of living with anything that affects what you can eat, but definitely, the people in this room especially. So I went through the research on psychosocial issues and HPEN, and these are some of the statistics that I found. So overall, you're going to see these weird ranges. I love the 10 to 90% range, or 80% range. I'm like, which one is it? That's a big range, and that's the problem with the research, right? Depending on who we ask, we try to get good representative samples of people, and we do statistics. I do this for a living at Northwestern. But I know my sample of 150 people with inflammatory bowel disease, it's kind of a crapshoot. Depending on who I got, it could be totally biased in one direction or another. So when I summarize research, I get these wide ranges. And so that just kind of highlights, not everybody is having the same experience, which is what makes this topic so complicated. But we do see problems across the spectrum of things, including intimacy and sexuality is impacted. Fatigue is another one that we see a lot of issues with, and fatigue kind of bleeds out into the other areas of life. If you're tired, you're not going to want to be doing other things. So those are some of the main points that we see in the research, kind of just summarized in one slide. So this is a study looking at health-related quality of life in people on long-term versus short-term HPEN. And you can see, so the lower it is on the graph, the worse the quality of life is. So the three main areas that are affected are intimacy or sexuality, traveling, and employment. The other areas, they all kind of track along the same lines, but those are the three main areas of health-related quality of life that seem to be impacted the most in patients on HPEN. So I really like a type of research called qualitative research. That's where we go out and interview people. We actually sit down and have conversations with patients. It's smaller numbers of patients, but the data that we get is much more robust, and it really gives us some really good feeling for what it is like to live with these issues. So this is a study that was done looking at stoma impacts, so if you have a stoma, and then also if you had to be hooked up. And so these are some representative quotes, and you can see that some are positive and some are negative. So just like those statistics, some people that were interviewed were like, this has been a lifesaver, it's really changed my life in a positive way, and other people were like, I can't do anything, I'm hooked up all the time. So again, even in these types of studies, we get a range of responses, but they kind of summarized them into this chart on the left, that it really came down to living with loss. Based on what the impacts were, either of the stoma or the need for the catheter, and then also what did they do to try and overcome that? What were some of the strategies that they used? And it was really trying to stay connected socially, trying to maintain meaningful activities was the largest coping strategy that people employed. Another issue that comes up is body image. I just did a webinar with Thrive a couple weeks ago on body image, which I'm sure is still available online. So I just wanted to give that a nod, since that was getting some attention recently, and how these things can affect body image. It's not just weight. We always think about weight, either loss or gain, but it has a lot more complexity when we're working with people such as yourselves dealing with these issues, because you have surgical scars, or you may have even had to have a colectomy or parts of your intestines removed, and so it's almost like losing a limb, but you've lost an internal body part that only you maybe can see, except for the scars that are left behind from the surgery. So the body image issues are much more complicated. We also look at things like prednisone, if you have to take that, the side effects that come from that. Not just the weight changes, but the acne and some of the hair loss, all these other issues that don't fall under the typical body image things that we talk about in broader society. So I found some quotes on how living on HPEN may affect body image. So it's anything, again, from trying to keep things hidden, which I'll talk about in a little while, the pros and cons of that, and then also concerns about the things that I mentioned, hair loss, weight loss, et cetera. So these are just some representative quotes from some patients that participated in a research study. So what are we doing about it? So unfortunately, there are a limited number of psychologists dedicated to chronic digestive disease, and there's probably even fewer that are dedicated to patients living on nutrition support. So I wish I could create more of us. We are trying very hard to do that, but so we have what we have, and I can present some of the things that we're trying to do. So again, back in 1979, like a magical year, Dr. Engel came up with the biopsychosocial model, which was a complete overhaul of the typical medical model that was being used for a very long time. So back in the day, we had this concept of dualism, that the body and mind are completely separate entities. And René Descartes came up with that a long time ago. So in 1979, again, I was 4 years old, this model came to be. And so we're trying to push this out into the mainstream medical world as an approach to use the biology, which is critical. I will acknowledge that forever, but we have to bring in the psychological, the social, and actually this model has been expanded to include spiritual as well. So it's more of a 4-point model than the 3-point model that Dr. Engel came up with back in 1979. So for medicine to be multidisciplinary, it has to really kind of bring in all of these parts of the biopsychosocial model, and by integrating these things, it makes medicine more humanistic, or getting at the human experience. So I wanted to just take a poll by raising your hand if you're comfortable with doing so. Have you experienced a multidisciplinary treatment model for your home nutrition? And I have including up there mental health support. Okay. Great. And how many of you had a multidisciplinary approach with no mental health support? So you got everything else, nursing, medicine, et cetera, but they left out the mental health side. Okay. So I went to look at the guidelines, and I looked at Aspen's guidelines for adults and pediatrics. And if I'm wrong, please correct me, but I looked at their website and pulled the most recent guidelines, which are a little bit old, and I did not see mental health or quality of life listed as a guideline for medical professionals working with patients on nutrition support. I also looked at the pediatric, and again, I did not see psychologists included in the discussion or mental health listed as a guideline. So I think this is an area where you as patients or professionals working in this arena can go to Aspen and the other organizations to say, we really need to start including psychologists who specialize in this in our guideline creation and kind of bring this into where people look for what should I do to help patients with nutrition support and get that actually into the guidelines if we can. Our friends over in Europe have done that, albeit to a limited extent. It is actually a guideline, I think it was number 9. And they do a brief mention also of depression, but it's mostly related to health-related quality of life, which is fine, but it was more than I saw in the Aspen guidelines. So unfortunately, we're operating from the biomedical model still, mostly in the home nutrition support world, and that's our friend René Descartes, and for my younger people, maybe they recognize the meme that I've just put on him. It's the scumbag meme, because his ideas are still pervading medicine, and it irritates me to no end that we can't bring biopsychosocial more mainstream than we've been able to. So what can patients do? So there's a concept in psychology called self-efficacy, which is a fancy term for, do I feel confident in my ability to do things? It's a broad term, but we also apply it to patients as well. If I feel like I can, I have the agency to do the things that I need to do to take care of myself on home nutrition, I'll do better. So raise your hand if you feel like you have decent self-efficacy related to your home nutrition? Okay. So in the research, we look at what helps people do better. And a lot of the findings were simply a passage of time. So the longer you've been living with this, the better you'll do. Being diagnosed or having to go on this at a younger age, so our pediatric patients tend to do better because they didn't have a lot of time, perhaps, living in a different way before they had to adjust back to a different way of life. So it kind of just became what they do, so they tend to do better. A pro tip for the traveling issue that came up on that graph was to send your supplies in advance. I don't know how logistically feasible that is, but that was something that came up. Positive social support, and then being connected to a patient organization, which I thought was great. So the Oley Foundation helps mental health. So social support. Have you told people in your life that you require home nutrition? And sometimes this is easier to hide, so if you can eat some foods, you don't necessarily have to disclose. And I could do a whole talk on disclosure and stigma and things like that. But it is important to tell people. You don't have to tell everybody, but we do know it is more stressful to keep a condition hidden 100% than it is to at least tell one person in your life. Who are the people in my network? I've learned, I live with Crohn's disease, I've learned having an illness is the best way to find out who your people are, and those people are often not the ones that you would expect. Oftentimes it's acquaintances and kind of these like peripheral friends that kind of come to our assistance, and the people that we would think would be the good supports don't tend to be. Online resources, the internet is a great place, it's also a terrible place, and so how much time you spend in like social support, chat rooms, etc. If you feel your shoulders going up like this when you're in like an online room, it's time to leave. It's time to close the computer and go outside, because they should be supportive, but they can be really scary too. The sicker patients tend to spend more time in chat rooms and message boards because they can't do things like other people can, and it can be very skewed in one direction. If people have seen chronic illness bingo, so I had an asterisk next to social support, and again, in telling people and disclosing, sometimes that brings us into chronic illness bingo. It's like, oh, have you tried this, or are you doing that, what did you do? It really can open up a can of worms depending on the quality of your circle, so we have to be careful sometimes of who you tell, or be prepared for ridiculous statements to be made. Michael J. Fox has a great quote on acceptance. And I talk about acceptance with patients a lot, and a lot of times they get mad at me, like, you're telling me to give up. I'm like, I'm not telling you to give up. I'm saying that this is not going to go away until they figure something out remarkable in the medical world, so we have to accept our situation versus trying to fight it. If we're constantly swimming upstream, we're going to have a harder time. So acceptance is a big area in psychology these days. There's actually something called acceptance and commitment therapy. It's a part of cognitive behavioral therapy theory that's come out more in the 1980s, and really gets at looking for values and meaningful activities in spite of the condition that we're living with. So really focusing on what are my values, what's going to bring me meaning and purpose, and doing my best every day to do a little bit of that. I think this is made available, so I put some links in there for some strategies and things to help with that as well. I'll let the people take their pictures. There's also the term resilience, and some people hate this word, and I get it. It's kind of a buzzword right now, but it is important to talk about resilience in this context. It kind of goes along the lines of acceptance, in that things are going to happen. How am I going to bounce back from it? And anxiety, a lot of the time, is expecting the worst case scenario and then completely undermining my ability to handle it. And I assume that I'm going to do poorly if I don't, if this situation happens, so I avoid and I do other things. And we are very resilient people. You guys have been through a lot. And so you've come out the other side. That does show resilience, but people are using this term as a way, I think, to try and encourage people to do better. So there's our natural resilience that we're born with, kind of our life drive. There's adaptive resilience, was what we've learned trial by fire, kind of what I'm talking about, what you've been through. And then there's also restored resilience, where I learn how to kind of tap back into some resilience things that I have that maybe I've lost sight of. So these are some strategies. I won't go through those. I'm running out of time. But really just looking at your thinking, not being too hard on yourself, focusing on, can I solve this problem or not? Do I need to let it go? And what are some self-care strategies that I can do? And some resilience resources as well. There's a lot of good stuff on the internet in these two areas. These were some quotes from that other study that I mentioned earlier. The takeaway of this slide is asking for help, having a good support system, to help manage the day-to-day of the home nutrition. So I flipped those statistics, so I wanted to kind of end on a positive note. If I flip those percentages, it's really not as bad as it looked the first slide. So most people are doing pretty good, on this. That doesn't mean we should ignore the issues, but it's also, like, if I only talk about the negative, I lose sight of the majority of these statistics are over 50% in the positive direction. So seeking help, when should you look for someone like me? If the things you're trying just aren't working, if you're feeling like I can't keep up with this anymore, I want someone to talk to, please reach out. You can see a clinical psychologist, a social worker. Psychiatrists tend to prescribe medication. They don't tend to do therapy. So if you want medication, that's your route. But if you want to talk to someone, it's not a psychiatrist, it's a psychologist, a social worker, or another therapist. You can ask specific questions. Any good therapist will answer these for you. References are more like professional references. Most people can't give out names of patients for you to talk to, but you can ask, hey, do you have any peers that could talk about your abilities to do this? That'd be perfectly fine to ask. Most of us accept insurance, and yes, insurance pays for my services. I have a very thriving private practice that is based on insurance, so the idea that insurance doesn't cover mental health is not true. So wrapping it up, this is a very broad area of impact, but most patients are doing pretty well. There are resources available for you, both online and then in human form, to come to and see if you need to. Getting that good support system in place will help, and then also staying connected with Oley will also be very beneficial. If you want to find me, you can find me at Northwestern here in Chicago. Also, my practice is out in Oak Park, which is a little bit south of here, and I am on social media as well. That's it.
And thank you so much, Tiffany, for joining us. Circumstances aren't perfect, but we really do appreciate it. That was very well said. And it's worth mentioning that a study out of the University of Kansas a while ago showed that people connected to the Oley Foundation have fewer catheter-related bloodstream infections, less depression, and overall better quality of life. So it really would be good to go home and talk more about Oley and bring more people in to benefit from those statistics. Our next speaker, Stomal Care Problems and Solutions, Jessica Salgado. And Jessica is an ostomy care nurse at the University of Illinois at Chicago. Surprise. Jessica, thank you for joining.
Good morning, everyone. I'm going to talk to you a little bit about ostomy care. A lot of these patients that we see in the hospital setting tend to have GI diseases that sometimes may or may not end up with an ostomy. So I'll briefly talk a little bit about the essential components of assessment. Sorry. And then I will talk about some complications and what we can do to prevent complications, but also what we can do to give better care for our patients. So a little bit about our assessment. We always want to focus on location. Location becomes very important because later on, patients may experience difficulty with being able to see to give their care for their ostomy pouch. In addition to that, being able to just kind of have a good quality of life, as mentioned by Dr. Tiffany. Making sure they're able to wear seat belts, making sure they're comfortable wearing their clothes, things like that. And then we want to make sure we're looking at color initially, especially post-op. We want to make sure that our color is always pink, red, moist, and then our shape. We also want to pay attention because that'll determine our teaching and how we take care of patients. In addition to that, we'll focus on tissue edges, whether they're intact or if there's a separation, because that will also can create problems that I'll talk about in a little bit. Some of the other things that we look at is protrusion, how big or how much the stoma protrudes from the abdomen. This is really important because, again, patients may experience complications later on when they go home, especially with their pouch staying on. And this can be very significant for their quality of life, you know, having leaking issues at home and things like that. In addition, we want to make sure that the stoma is moist. And then pay attention if there's a surgical bar. Sometimes with the loop ileostomies, physicians will leave a bar. Depending on that, that'll also kind of drive our care for patients. And then just paying attention to the amount of bleeding. A lot of the times patients associate bleeding with bad or that something's going on. But we want to make sure that we're educating our patients to understand that how much is okay and how much isn't. So some of the complications that we tend to see after a stoma procedure, some of the earlier ons are mucocutaneous separation, stoma necrosis, retraction, that can actually occur early on and later on, stoma stenosis, stoma prolapse, stoma laceration, and a peristomal hernia. So I'll focus a little bit about our mucocutaneous separation. This often tells us if it's a poor sign of healing, which we know that nutrition plays an essential component to this. A lot of the times patients that are on steroids or immunosuppressed, diabetic, or have a history of radiation, or malnutrition or obesity. We want to pay attention closely to where the defect is and be able to assess the depth with, and just kind of, you know, get a thorough understanding of why this is happening and what we can, so that it can guide our care. So what we do typically as ostomy nurses, we want to make sure that we're covering that defect so that we make a plain field so that the pouch can stick. Essentially, the goal is to make the pouch stay on for as long as possible, 3 to 4 days, and then that'll essentially allow some of that skin under there to heal. Some of the things that we can do is, you know, fill in with powder, fill in with paste, although a lot of the times I'm very hesitant to use paste because it does contain alcohol, and this can be very painful to patients. Sometimes what I use can be also alginate, hydrophora blue. We know these dressings are really, really absorbent, especially the alginate, so we want to make sure that we're using an absorbent dressing. This will kind of ensure that we do get a good seal on that pouch and that it can stay on for a good amount of time. And then we just kind of fit in that barrier over the affected area. Okay, we have patients that you may see necrosis. In this case, a lot of the times you will see it initially after surgery. Some of the risk factors can be surgical technique. If there's not sufficient blood flow to the stoma, that can create some necrosis. If there's tension under the suture line, if the patient is on vasopressors, again, history of radiation, or if there's a clot. Typically what we can do is surgery, but before we get there, we want to make sure that the necrosis is truly necrotic bowel, and the way we can do that is by inserting a clear tube, and shining a light. This will kind of allow us to see inside the bowel to see if the necrosis is superficial or not. And then I kind of threw in this slide because a lot of the times the bowel may look a little bit necrosis, but it may not necessarily be. This is usually a patient that has had excessive laxative use. As I mentioned earlier, stenosis may occur early on or later on once the patients are home. Some of the things that can occur from this is obstruction. You may see the stool come out ribbon-like. So what we want to do is, you know, again, making sure that a pouching system is working for the patient, and just kind of making sure that the patient is comfortable, because again, being able to, you know, this may create constipation, it may create a small bowel obstruction, so being able, and then, or it may create some peristomal skin issues. So again, just making sure that we are assessing this stoma so that we can prevent future complications. Some of the treatment can mean surgical revision to pull out the bowel more into the abdomen, weight loss, you know, keeping up, making sure that the appliance that they have on is appropriate or adjusting, and then maintaining soft stool and hydration. Like stenosis, we may also see retraction. This means when the stoma is below the at or below the abdomen skin level. Patient may report pouching issues, and they may have a lot of skin excoriation around the stoma. A lot of the patients will report that their skin is red, moist, weepy, and that they're having trouble getting an appliance to stick. This becomes kind of a vicious cycle, because again, if the pouch is not sticking, the patient will have more skin irritation, more leakage, and it just kind of keeps going. So what we want to do is make sure, okay. So what we want to do is make sure that they have the appropriate pouching system. A lot of the times, if your patient, you know, we have different accessories, different things that we can use with our bagging techniques. We would want to consider a convex pouch with this patient. We would want to consider rings or paste, or even the use of an ostomy belt, just to create more convexity and more of a plain field, so that the stoma sticks out more into the bag. Yep. Sometimes we may see a prolapse. So this is when the stoma telescopes out into the bag or out of the abdomen. This is most commonly seen with loop colostomies. They may appear dusky in color. A lot of the times this occurs because of surgical technique, if there's increased abdominal pressure or edema to the bowel. So what we want to do is reduce edema. We want to make sure that we can sprinkle some sugar to the stoma, and that'll actually reduce some of the swelling, or use a cool cloth over the stoma to kind of decrease that swelling. As far as pouching, we want to resize the pouch, and then so that it adjusts to the bigger size of the stoma, and then consider using a hernia support belt. So we also see peristomal hernias. This can typically occur if the stoma was placed outside the rectus muscle. So like I mentioned earlier, location becomes really important. If the stoma is located outside the abdominal muscle, a patient can develop a peristomal hernia. So again, that's where pre-surgical education and pre-surgical marking of the stoma becomes really, really important. Some of the things that we can do, as I mentioned, for prevention, we want to pre-op mark the stoma site. We want to avoid lifting or advising our patients to lift anything heavier than 5 to 10 pounds, and avoid excessive weight gain. Again, treatment really is important on how to make sure that our pouch is staying on. So we want to make sure that we're resizing the barrier, using a hernia support belt, and then just, you know, advising if it's appropriate, a patient may do irrigation. So some of the things that we see around the stoma and more of the skin is irritant dermatitis. This can happen again if the stoma is not protruding enough, or if it's in an appropriate location where the patient may have a crease or a scar that developed. Again, the big thing with this is making sure that we have an appropriate pouching system. So things that you may see is superficial erythema, or the patient may report to you that they are experiencing some burning pain. So again, like most of the treatments I mentioned earlier, making sure that the pouching system is the most appropriate, whether it's using things like powder, skin protectant, a convex barrier, just kind of assessing and making sure that whatever is causing the leak is addressed. Then we may see a fungal infection as well. A lot of the times you may not hear a patient say that their pouch is leaking, but that doesn't necessarily mean that it's not. Especially patients with colostomies where the stool is a little bit thicker. This stool can trap underneath the barrier if the barrier is not appropriately sized. And what can happen is then it creates a fungal infection that will present similar to the picture here. You may see a papular rash with satellite lesions, kind of scattered red dots. A lot of the times what we do recommend is an antifungal for this or steroid treatment. Okay, I mentioned that. Another complication that is a little bit more rare that we do, but we still do see is pyoderma. What this looks like is really, really, really red, purple lesions. Sometimes they're irregular in shape, and they are described as very, very painful for patients. You know, even just kind of getting air on it, patients are screaming in pain. There's a lot of exudate that comes from there, so a lot of drainage is always present. And we tend to see these lesions occur with patients that have IBD issues, history of leukemia or myeloma, and then just more of the autoimmune inflammatory diseases. So some of the treatment is basically similar to what I've mentioned before, is making sure that we're kind of getting a good pouch to stay on. This becomes really difficult because these wounds tend to drain a lot. So some of the dressings that we want to consider is alginate or hydrophora blue. Personally, I've had a lot of success with alginate dressing, and then just securing that with a secondary dressing like a duoderm, so that it becomes, because a duoderm dressing is a little bit more occlusive, we know that we're kind of stopping the stool from getting to the wound. And then a little bit of what we see also is fistulas, which are sometimes complications from surgery that we may or may not see. And this is managed very similarly to ostomy care. They, again, will fill in any defects or any creases or anything like that. We pouch with a good pouching system, making sure that it's cut to the appropriate size. And then just kind of basically managing it medically. Physicians may do TPN nutrition for this and things like that. And that's it.
Thank you, Jessica. Our next speaker is Dr. Richard McCallum, who just got in late last night. Richard is professor of medicine and chief of gastroenterology at Texas Tech University, and I think you'll note his unique Texan accent. Well, not really, but Richard?
Good. Well, thank you very much, Joan, for inviting me. We're going to discuss, I think, some things that might be of interest to you as patients. Some things we worry about every day, some of the new work that's being done around the country, and see if some of it can be integrated into your life, into your world, and help some of your patients. So we do some research with a number of companies. I don't think any of this will interfere with an unbiased presentation, I hope, of the data that is available today. So one of the biggest things that's happened in the gastroparesis world is that 15 years ago, the NIH decided to sort of develop a consortium, fund those centers that do a lot of work, because no one center ever has enough patients to make a statement. You may publish 25 or 30 patients, think you're doing well. That's not representative of the real entity, which may be hundreds. So we have the top 6 or 7 centers in the country that work in gastrointestinal motility problems. And we've sort of combined forces under the auspices of the NIH, gave us some funding, and we are listed up there. And these are important places for you to think about. One of the biggest problems you have is basically wandering the world trying to find salvation. And you spend a boatload of money. And basically, the average GI doctor does not know this stuff, and you need to understand that. He's worried about doing endoscopy and making money. That's what's going on in real life in USA. There's only a few people that want to take the time to actually talk to a patient. After you've done 3 CT scans, 5 endoscopies, and everything else, we may have a conversation. Now, that's not the way medicine was ever meant to be. We have a long conversation first, and we may do no tests. It may be very evident what the diagnosis is. And those people are only found in certain centers. And it'd be very wise for you to work through Oley, through the American Motility Society, Angela DeGrazia de Tucci Society, other societies where they list places that actually have an interest in you. It's not everyone, and you may have to travel a little bit to get to those places. But that investment far exceeds the money you've spent wandering the country searching for hope, because this is not something the average doctor understands, and that's a very important point to make. So, these are the things that are burdens on your life that are not surprising, perhaps, but obviously that's a given. Abdominal pain has crept in. We used to call it discomfort. We'd sort of make light of it, but pain is front and center now, and it's been ignored to a large degree, and we have to worry about how do we treat pain. Gastric emptying is the gold standard. This is the Bible. You can't have a touch of gastroparesis. It's not like a touch of pregnancy. You either have it or you don't. And the only way to find out whether you've got it is to do a definitive study. It's not someone saw some food in my stomach on endoscopy. Someone told me, the upper GI series looks slow. That's rubbish. The only way to diagnose it is to do a real study. We spent many years maturing this study, and it's a 4-hour gastric emptying study using isotope-labeled egg beta meal. 250 calories, the two are worked out. You can be rapid, you can have dumping syndrome as well, or you can be slow and empty less than 90% or have greater than 10%, often more than 20% present later on. And then there's a group of patients that have chronic unexplained nausea and vomiting who go for a gastric emptying, and it's normal. That doesn't mean we dismiss you and regard you as, seeking medical care in some sort of disguise or guise. We recognize that there is an entity that we're still understanding why you have the similar symptoms. It's called gastroparesis-like. And yet, when we do the final test, it's not that impressive. Are you a diabetic who's evolving into gastroparesis? Are you a viral gastroenteritis patient who damaged their stomach and now it's getting better with time. This is work in progress. Let's be very sure we have the right entity. The commonest cause of vomiting in the world today is this entity. Under-recognized, under-treated, but they end up in my office every day. And we're doing nocturnal phone calls every day to patients who say, "Doctor, I can't stop vomiting. You've got to do something." So the first thing I do is take a history. And this is the commonest cause of vomiting in the world today. I eat a meal, and within minutes, 15 to 20 minutes, the food is coming up into my mouth spontaneously like a fountain. Belching and burping may precede it. I have abdominal pain from contracting my rectus muscle. It's called abdominal wall pain. It's associated invariably with a very significant event in your life. Loss of a loved one, a major setback, divorce, relocation, perhaps other issues of abuse that have been going on for some time. Very clear, and it can overlap gastroparesis. About 75% of patients are uninvolved with gastroparesis. They have this spontaneous ability to ruminate and bring up food within minutes of eating. Cyclic vomiting is the other thing you don't want to miss. Every month or two, I have dramatic attacks of pain and vomiting, out of the blue. In between, I'm relatively okay. That's not gastroparesis. That's cyclic vomiting syndrome, typically involved with stress, migraine, diabetes, or marijuana use. That's the new kid on the block. Marijuana may feel great, sound great, but if you take it every day for 4 or 5 years, you could easily begin cycles of vomiting and pain, called cyclic vomiting syndrome. You store it more, you have a lower sensitivity, a lower threshold for vomiting, it's out there. Relief by hot baths and showers may be present as well. And then there's dumping syndrome. I empty the food so rapidly, I have abdominal pain, cramping, diarrhea, hypoglycemia after a meal. Again, diabetes, vagotomy, idiopathic. So these are the players out there. Not everyone who vomits has gastroparesis. In actual fact, it's the minority. How do we treat it? Well, I'll go through the highlights in the time we have. We can't go all through these. You've heard a bit about diet in the past. Obviously, that's the front and center part of it. These are the antiemetics that you'll be exposed to one way or another. You'll be given the ABCs, the garden variety, compazine, phenergan, Zofran. Then you may elevate to Marinol, which is a marijuana-like product, which can help appetite as well. Scopolamine patches I use frequently behind the ear, 3 days of continuous coverage. Amend or aprepitant we'll get to. Prokinetics, Reglan, and Motility have, in addition, important antiemetic properties. Erythromycin is a straightforward prokinetic, stimulates your motility. And these are agents that you may be exposed to, tricyclics and SSRIs. Domperidone is the world's best drug right now for nausea, vomiting, and gastroparesis, even just for nausea and vomiting. Came out of chemotherapy, cancer, it works. Some people in this country, like I do, have an FDA protocol, and we use it every day. Others get it from Canada or from Mexico, or have it compounded in your local friendly compounding pharmacy. It's a very, very important agent. It improves gastroparesis symptoms. There is a risk of cardiac issues, but if you do very careful cardiograms, we don't see QT interval problems. We see it in less than 10% of patients. This is an abstract we presented at DDW. talking about the importance of domperidone in relieving nausea and improving quality of life. Aprepitant is a special new agent which blocks substance P in the chemoreceptor trigger zone. We did a study with the Gastroparesis Consortium, published it recently in Gastroenterology, and we found that indeed it does overall improve nausea and improve some other aspects of the gastroparesis score called the Gastroparesis Cardinal Symptom Index. So this drug can be accepted. It's a little bit expensive on a chronic long-term basis, but can be used intermittently to try to help control nausea and vomiting. Tricyclics are used commonly, anxiety, modifying pain. Do they help gastroparesis? This is a JAMA published article we did about 3 years ago. Overall, it did not improve symptoms compared to placebo in idiopathic patients. But with higher doses, we did see an improvement with appetite, satiety, and body weight. We didn't get to very high doses in some people because of side effects. Abdominal pain, how to get into this area, 34% of people may talk about it. Some even go to the emergency room. How do we avoid opiates? Opiate use was present in our patients. Recently we did a study, 41% of our patients, 600 people in our study, used variable degrees of opioids. How do we get around that? Well, we play with tramadol is sort of acceptable. I go up to 100 milligrams maybe 3 times a day. We use tricyclics. We use SSRIs, Cymbalta, SNRI. We may use gabapentin and Lyrica to try to modulate pain. Now and again, I have to go to a fentanyl patch. I'd rather put you on a fentanyl patch than meet you in the ER, where it's cost you $500 to talk to ER guys who wouldn't know gastroparesis from a hole in the wall, and you get another 3 CAT scans and God knows what, and go home with a $4,000 bill. That's not a productive visit. So sometimes we use fentanyl patches. I may get you addicted, but you're functioning, raising a family, and working. Not my first choice, but it may be my last choice to keep you out of the ER. Over time, what happens to me, doctor? Is there any hope? There is hope. Idiopathic is often induced by viruses and gastroenteritis infections. Could last a year to 3, but over time, patients with idiopathic tend to get better, tends to improve. It tends to get no better in patients with diabetes. They tend to have the bad prognostic sign. It's a chronic, long-term situation where it may even get worse. Idiopathics tend to get better and normalize over time. What's in the future for you? Well, it's a hot area, a very hot area. There's many drugs in phase 3 trying to jump over the hurdle in Rockville, Maryland, and get the FDA to approve me. We have a ghrelin agonist in phase 3. We have a 5-HT4 antagonist, Lucitrag, but we just had a 5-HT4 agonist approved, prucalopride, 2 milligrams for constipation. It'll be used like water everywhere in the GI tract to improve gastric emptying, esophageal reflux, pseudo-obstruction. We'll see it everywhere. Where it'll be the most suited, we'll have to wait and see, but it is approved. You can use it. Metoclopramide is a nasal spray, may help you absorb it when you're not feeling well and you can't be guaranteed to keep it down. There's new domperidone agents by Takeda that have no cardiogram effects, and we'll see that evolving. Where does gastric electrical stimulation stand? Came in 2000. We put electrodes about 10 centimeters from your pylorus, and we hooked you up to a stimulator under your skin subcutaneously. what we learned is that over time, and this is our gastroparesis consortium study, we took patients on stimulation versus those who never got it. Where are you today? Our conclusions were that they're more likely to be improved on a stimulator. 15% of our patients required it. About 30% of my patients require it. And they're likely to show some improvement over 48 weeks versus those who did not have a gastric stimulator. But it's been disappointing, and we were sold a bill of goods by Medtronic. This is not a front and center agent for improving gastric emptying. What it does is it blocks nausea by lighting up the thalamus and the vagal nuclei by a PET scan. It does not improve gastric emptying. It does not change the electrical rhythm. It does not improve abdominal pain. It may allow you to eat a bit more by relaxing your fundus. So the big move right now is to move on to the bottom line. Why can't my stomach empty? And the pyloric revolution is alive and well and evolving. And it just makes the point that, yes, you've got all this vagal nerve involvement, impaired interstitial cells of Cajal, disordered electrical rhythm, tachygastria. But bottom line is I've got to get through a little canal called the pylorus. Unless I get through there, we're going nowhere. And it may look open, may look benign, but that may be a very tight, non-cooperative sphincter. And indeed it is. And now we're doing studies to biopsy and look at the pylorus, and lo and behold, it has an absence of what's called interstitial cells of Cajal, which are the bottom line to have your muscles contract and your sphincters relax. And there's none in 80% of our pylorisis of gastroparesis patients. And they've got a lot of fibrosis. So the pylorus is not working, so the move now is to do a stimulator and a pyloroplasty. And here's our patients here, where we have 75 to 80% improvement by doing a simultaneous pyloroplasty and gastric stimulator. And the big study right now we're doing is the question, do you need a stimulator? We're doing both. And you're giving me 6 months of your life, and I'm not going to turn you on. I'm going to turn half on, half off. And over 6 months, we're going to find out, did you need the stimulator or not? Or could you have done just as well with a pyloroplasty? We think a stimulator is most involved with nausea. You still may need it for nausea, but your gastric emptying will be normalized and you will be functional with a pyloroplasty. What else beyond the stomach do we measure? We measure small bowel and colonic transit by smart pill or wireless motility capsule, a little capsule that involves pressure, temperature, and motility. We swallow it. It's about a big multivitamin size. And here you are, leaving the stomach. Swallow it with a bar, caloric bar of 250 calories. It's initially neutralized with your acid. Then it goes down. The acid is left. It's very acidic. All of a sudden, it jumps up into the duodenum. That's gastric emptying through the pylorus. Here's the cecum, drops down a bit, and here it goes out through the rectum. And we have data on what is normal gastric emptying, what is normal small bowel transit to the cecum, what is colonic transit, and we can see where you fit. Certainly constipated patients have more upper GI symptoms, and about a third of gastroparetics have accompanying severe colonic weakness or colonic hypomotility, which makes their gastroparesis more difficult to manage. SIBO is a hot ticket. Everyone thinks they've got it. Well, do you have it? Bloating and gas, unexplained. Increased belching, passage of gas, postprandial distension, bloating. Diffuse discomfort, typically postprandial driven. Gases and noises, borborygmi. Unexplained diarrhea can be explosive, particularly at night, can even be accompanied by fecal incontinence. These are the telltale signs. accompanying weight loss and nausea. How do we diagnose it? We do a breath test. You come in and get a glucose breath test. And you don't use lactulose. Let me repeat that twice. You do not use lactulose, okay? That's rubbish. The test for SIBO is glucose, and it goes up above 20 parts per million. And we have a number of explanations, typically PPI therapy, previous surgeries, diabetes, and weak motility. I'll refer you to my book as well for further discussion, and I'll be glad to take a few questions because I'm running out of time. Thank you very much.
Take questions here, so just have a seat there. Pass the mic around. Okay, well, we have time for some questions if people can come up to the microphones. Richard, I have a question for you. You know, almost all drugs that are taken by mouth are absorbed in the proximal intestine. So what happens, even in the study drug, procalamine or whatever, they're sitting in the stomach. So if you have a patient with severe gastroparesis, how's the drug ever going to work if it doesn't get out of the stomach?
Well, you know,
Relative.
So you don't empty 90% by 4 hours, but 4 hours later you're all forgiven and it's dribbling down your gut. So if you take a drug 2 or 3 times a day, in case of precalcipride it'd be once a day, over the next 4 to 5 days you are going to get some kind of plasma consistency. It will be absorbed slowly, eventually you get a blood level and things go on. So it's not going to happen today. Antiemetics may happen today if you take scopolamine patches or something that's absorbed, but it takes a day or 2 in gastroparesis to get into the blood. That's a good question.
Okay. At the microphone?
Yeah, I was wondering, I have a couple of things.
Stand a little closer to the mic. So
About 14 years ago, I had a pacemaker implanted and the lead dislodged, and it was in the diaphragm area, and for about 3 weeks, my stomach was just boom, boom, boom. And I have gastroparesis, and it seemed to help. So why would that be different than the gastric stimulator? And can you have a gastric stimulator now if you already have one appliance?
Yeah, so your question is about is it the problem with
Well, yeah,
the
it was,
or was it?
because you were saying the gastric stimulator has to have a lot of thought before doing it for gastroparesis. Well, I had my first pacemaker implant and the lead dislodged. It was in my diaphragm and stomach area on the outside. And so it was in essence pacing my abdomen because it would jump like all the time. And I have severe gastroparesis with nerve, I have autonomic nerve failure. So anyway, I was wondering how that would be different than when the gastric pacemaker worked the same or not. Was that different that I got relief during that 2 weeks that it was dislodged, or just luck?
Well, let me just cover a couple of things. First of all, the gastric stimulator has often been oversold and overrepresented. It only affects nausea. It's not going to make your stomach faster or improve your electrical dysfunction. So it does improve nausea, but overall, if I ask you how you're feeling, we never get above 50% because your gastric emptying is still slow, and that's a major player in your symptoms. As far as the feeling of jumping or something happening under the skin, this could be vibrations from the electrical rhythm. Sometimes it turns on itself or tips, and we do hear about patients. I have patients with funny sensations and discomfort. I have moved it around. Sometimes you're touching a nerve from the surgery. There's been some disturbance of the innervation of the skin. And the question originally may have been, was it put in for the right reason? Many times it's not well studied before you get it, and you expect a miracle. It's been sold as the final solution. It was wrongly positioned that way, and many patients perhaps their expectations were high. But it has a role, but a diminishing role every year.
Well, I started with Dr. Satish Rao, and I went through Bowery training for over 12 years with him and took Cisapride. And then once Cisapride went off the market, nothing has worked for my gut since. We got some from Mexico, but it didn't jumpstart anything. So in essence, I had to have my large colon removed. Now I have an ileostomy, and now I have like almost kind of short bowel, just a liquid now, and now I don't absorb.
Well, cisapride was a great drug. Prucalopride might try to mimic it. It works through a 5-HT serotonin mechanism. If your symptoms are nausea, I would certainly get domperidone. It's the best drug in the world, and it does have a motility component. Try prucalopride when it comes out. It's out now. And stay tuned for these new 5-HT4 agonists that are en route. But if your stomach's not empty, still, you need a pyloroplasty.
Okay.
Let's take a question over here.
Hi, I have a question about therapy, especially for kids. We have a 5-year-old who's been shortcut since birth and TP independent. Do you think it's a good idea to start therapy while he's young? And if so, like what kind would you recommend? And I should also recommend he's got some verbal delays. He understands everything, but he just can't speak everything. So talk therapy wouldn't work for him.
That's a great question. Yes, so we take a lot of the stuff I do with adults and we modify it for children. I have they're called pediatric psychologists, and I have one in my group who goes down to as young as age 5. And so it's a lot of play therapy. I often joke, there's all these games and Play-Doh and art supplies that I don't get to use much with my adult patients, and maybe I should. Because they have fun, and it is effective, though. So it's not just playing together. And so the earlier you can, the better. It really, these kids are learning these skills at such a young age. It's harder to learn them as an adult. So if you feel like he would be open to trying, take him in and see how it goes, and look for pediatric psychologists.
Okay.
Those are the ones that are trained to do that type of work.
All right, thank you.
Over this microphone.
Question for Dr. McCallum about the pyloroplasty. How long has your center been doing it, and about how many do you do a year?
How many what? Oh, so the pyloroplasty question. So I didn't put the slides up because I really don't want to mislead audiences. One of the things about reading journals and Googling whatever else you do is you read these emerging therapies that, you know, someone's reported 10 cases of this, someone does 25 of that. That's interesting at our level. These are what's called emerging therapies, and they're interesting. We do an endoscopic pyloroplasty where we can cut the muscle endoscopically. Some people are putting vents or stents in the pylorus to open them up. Quite frankly, they never stay long. I didn't show you that data because right now the only data in stone that I would do for my sister or brother or mother is a surgical pyloroplasty. That's all we know today that works. There's interesting stuff out there, but one of the problems is you can get misled by reports. 10 of this and 20 of that. They don't count. When we do 100 or 200, we start to take notice in medicine, and we don't mislead people. This is your life. We don't jump in and do things just because they're topical or fancy or new. We wait till it's proven and real. So the only study right now, any work right now that's proven is pyloroplasty done surgically by a guy that's been trained for 20 years to cut the pylorus, not some fast endoscopy guy who's done 3 endoscopically. I'm not going to have one of those guys touch me. So the question is, yeah, we're doing a surgical pyloroplasty every 2 weeks. Every time I do a gastric stimulator, I cut the pylorus, and we get tissue from the pylorus, we study it. And the pylorus is invariably extremely diseased, and it was never appreciated. So the major way to treat gastroparesis is to cut the pylorus. The stimulator is a bonus. I want to get your stomach emptying and working. It's like your heart. We can give you many drugs, but unless your heart has actually got a good ejection fraction and you're moving blood around the body, you're in heart failure. You're still in stomach failure, even though you have a stimulator. That's not enough for me. I want to resurrect your stomach.
And when you say do it surgically, is it by laparoscopy?
Yes.
Okay.
Laparoscopic, you're home in 2 days.
Okay, thank you.
Is domperidone available for children, and if not, do you see it in the future?
Is domperidone available for kids?
Domperidone, no, that's a good question. I don't go under 17 as a rule. Quite frankly, there's no reason not to use it. Its only side effect is to increase prolactin, which may interfere with menstrual cycles, may decrease menstrual cycles, and may lead to breast enlargement in women, obviously. I think the 5 or 10% of cardiac QT intervals, we wouldn't use it in fibrillation. We wouldn't use it in a child who's had congenital heart surgery or has had any serious cardiac issues. But although I don't use it myself, I personally would think it's not unreasonable to use in children. I don't know what the European rule is. I don't know what the European rule is. It's been approved in Europe for 25, 30 years. I don't know how many children have experienced domperidone, but quite frankly, if your nausea is uncontrollable and your gastroparesis is not responding, you'd have to think about the gastric pyloroplasty stimulator, or try domperidone to buy time and hope that your viral gastroparesis or whatever the insult was will resolve. But I would try patches. Have you used patches?
No. My daughter's been on Reglan for 9 years now, so I'm just wondering what the next step would be if Reglan decided to fail.
Yeah, I'm having trouble with the...
What would be the next step?
If Reglan fails, is this orally failing?
Not yet.
Well, there's 2 tricks with Reglan. One is to give it subcutaneously. Okay, just like in the ER, you get IV Reglan, and things seem to run well if you're not allergic. We give it sub-Q. So we teach you to give an injection under your skin, just like a diabetic. It's the only drug that's allowed, it can be given sub-Q. So you can walk around giving yourself subcutaneous injection 2 or 3 times a day to head off and prevent a relapse of your nausea and vomiting. And if someone calls me, I say, do that before you come to the ER. It's 80% as good as IV. So you can look just as good as the guy in the ER giving you IV and saving $300.
So then if oral fails, then sub-Q would be the next step.
It's what?
If oral fails, the sub-Q would be the next step, is what you're saying.
Yeah, I'd say if you don't have any side effects from the oral, but it didn't work, try sub-Q before you give up. And then you may have to go to domperidone. I might go to scopolamine patches because it's in this country, and I haven't got to get fancy ways to find it. I use patches a lot. They last 3 days behind your ear, and they're very effective, but you can't absorb much.
Okay, great. Thank you.
Thank you.
I'm going to ask a quick question for Jessica to get her in the action here. So, Jessica, if somebody's gained weight and say their appliance isn't fitting right or they've noticed some problems, can they get to an enterostomal nurse directly, or do you have to go through the surgeon or gastroenterologist or what have you?
Typically, yeah, we just have patients. At UIC, we give our phone or our pager out, and then they contact us, and we see them in outpatient clinics. Yeah, to kind of try to prevent any ER visits, pretty much for just about anything.
Doug?
Well, all the presentations were excellent. Dr. McCallum, question on enteral feeding tubes, putting in gastrostomies, jejunostomies, or gastrojejunostomies. Do you have an approach for different situations?
Quite frankly, I'm not a big peg page guy, okay? Because I'm the guy Saturday night that comes in after my patient has vomited all day and has vomited the peg back into their stomach. And we've got to thread it down at midnight through the pylorus. I'm not a big in favor of putting a peg in to vent. Venting is an excuse to procrastinate and buy time and go nowhere. I'm not big on venting because I'm simply decompressing my stomach and I'm stopping it from expanding again and getting used to working. I do a surgical J. Why? Because I want my surgeon at the same time as he opens the abdomen laparoscopically to take a piece of your stomach, a biopsy. And then I will know tomorrow whether your stomach has the right stuff. Do you have the interstitial cells of Cajal? Is your muscle with us? Do you have scleroderma? What is your enteric nervous system like? And that tube is 2 or 3 feet below trites. You're never going to vomit Ensure into your mouth. We're just going to worry about flow rates. Do you do it at night? All these simple things. The other tubes have endless ups and downs. So quite frankly, I'm afraid I may do a peg-pedge for 2 weeks to buy time to get you, gain some weight and get you out of the hospital, then take it out. But if you're looking at 3 months or more of tube feeding, I'm going to a surgical J.
Next question.
Denise Richardson. I'm a pediatric nurse specializing in nutrition support, and that's been my career for many, many years. And Joan had a quick question for Jessica. She wanted to make sure, I'm sorry, the woman in the middle. When patients are discharged, do they know who to call? Is there always when it comes to your area, that they know exactly what they should be doing? That was her quick question.
Yeah,
I have a little one.
Thank you. So a lot of the times before discharge, we set the patient up with a follow-up appointment with the surgeon, and we kind of tie that in together, and I'll make sure that either myself or my colleague is available. The other thing is we do give them our pager number so that they can contact us, just because, again, we want to make sure we're preventing any ER visits, or something. A lot of the times the ER staff may not be familiar with stoma care, so we try to get them in clinic as, as they...
So they know where
Yeah.
it's set up. Perfect.
Yeah.
So for me, excuse me, what I want to say is, as a clinician, I enjoyed all 3 speakers. This session was really well done. You did a great job. It was such a nice review for us. For me, on the Stomal, it was just perfect. And all 3. But Dr. Taft, my question real quick, or comments. So as a nurse that's been working with kids and families for so long on TPN and enteral, I've always been really passionate about psych and getting people involved early. I think now the intestinal failure programs often have a doc at the table, psych is at the table, they're involved, so that they have a good support. I don't know how much that happens around the country in lesser or programs, that don't have programs like that. But so like I said, I was really passionate even before psych was involved. It seemed to be, and I'm a nurse, that the docs, the rest of the disciplines in my mind, didn't really recognize the importance of getting that done. And I would always say, it's chronic illness. These kids, they really need to, either themselves as young adolescents or the parents, that you really need to start very early. This woman's question about a 5-year-old, I don't think that's ever too early, of course. And the other comment, I guess 2 things. You talk about insurance. Although it is covered, it seems to be the biggest, I don't know why it's such an area that, you can call 10 psychologists, 10 people, and I don't take your insurance, I'm taking care. So you just keep calling. So that's frustrating, and although it's covered. And then the last thing I would say is, as a parent who's actually used to take my kid to psych, he had really bad ADHD and really needed to focus. And I would say, talk about the difference to patients in terms of the social worker role, the levels, and psychopharm, like you said, psychiatrist really isn't who you want. So I kind of would guide people on that in my practice. And also that encourage my patients and the parents to say, it might not be a good fit right away. Give it a few months. Give it a couple months with one person, or you really need to see, and you'll know then if it's a good fit or not, and male versus female, that person, to consider that. So that's a lot of points all over, but I just want to say it's been,
I just
really
want to give
important.
a shout out to the nurses, because you definitely have been ahead of the curve in terms of recognizing the role of psych.
Yeah.
I feel like we are riding kind of that wave of nursing. A lot of our early research support was from the nursing arm of the NIH. So a lot of the psych studies in GI are published in gastro nursing. So you've been wonderful in helping us facilitate that. And there is going to be, unfortunately, wide disparities in terms of what centers have psych. Northwestern has an entire behavioral medicine team. You know, most of the universities in Chicago have at least one psychologist, but then you start getting out into other parts of the country and that just falls considerably down. So we would love to have a psychologist everywhere. And so I just wanted to say thank you for the work that you've done on that.
Okay, we're going to take one last question, then we're going to move to the next session because we're running a little bit behind.
Okay, I just wanted to ask Jessica a question. You spoke mostly about ileostomies and colostomies, but what about the soreness that we get from G tubes, J tubes, GJ tubes around our sites? That wasn't mentioned at all.
Yeah, so we also, at UIC, we also see a lot of that as well. A lot of the care just kind of revolves around the amount of drainage that is coming out around the site. So we typically, for treatment, we will do either moisture barrier cream to kind of help soothe that skin, or a nice skin protectant just to kind of proactively protect the skin from excoriation. But yeah, it's something that I think is really painful for patients, and we do see quite a bit.
And sometimes you can get some granulation tissue from the tube, you know, when the hole gets a little bit too big, and your gastroenterologist or surgeon can use these little silver nitrate, or a stomal nurse can use these little silver nitrate sticks to sort of cauterize that area. So,
one comment. Recently, we had a patient who, for some reason, had a pig tube for like 4 years, and we finally talked him out of it. He was sort of psychologically committed to his peg, although he was intermittently eating. So we took it out in all good faith and told him it would stop draining over time, hopefully. Put him on a PPI to stop the acid coming out of the hole and hurting the skin. But a month later, he was still having drainage. So we did a endoscopic procedure, and we sutured the hole in the stomach with endoscopic clips. We clipped it. A month later, it was still leaking. We had to go in surgically and actually suture and close that hole. So you know, sometimes if the tube is in that long, that was a long 4 years. But sometimes they do not. We always say to the patient, it'll heal spontaneously. But there are rare cases where it does not close and the drainage goes on.
all right, well, thank you very much, panel. We're going to move on to the next speaker.
Thank you very much. Really excellent session. And our next speaker is an old friend, well, bad choice of words, a long-time friend of Oley, Dr. Mark DeLegge, and the topic is choosing the right tube for the right spot. Dr. DeLegge.
So I'm Mark DeLegge. I'm a gastroenterologist, hepatologist, nutritional physician, and I've been doing this since 1989. And frankly, just want to say before we get started, it wholly changed my life. When I first met Lynn Howard, who and introduced me to Oley, coming here was something that had tremendous impact on me, because it's easy as a physician to lose sight of the patients that are involved in all that occurs in medicine. So before we get started, Joan asked me to talk about the right tube for the right spot, and as a gastroenterologist, I said, wonder what tubes they mean, because I put tubes everywhere. So I wonder if they want to hear about rectal tubes. So I said, now, but using my filter, I said, probably not. We don't want to hear about rectal tubes today, so we're leaving that off the menu. Joan, what do I do with this thing here? Green arrow? Okay, hang on. Oops. I got it. So let me tell you a story. So one person, that impacted my life. This is when I was first in gastroenterology. My first PEG tube that I put in was on a gentleman called the Prince. So I was in Richmond, Virginia, and the Prince was one bad hombre and had a gunshot wound to the head. I don't know all the details. I just know what I know from people that told me about the Prince. But he was in bad shape and frankly did not make a great recovery. Survived, but did not make a great recovery. But I remember that he was in the neuroscience intensive care unit amongst other people with major issues. And we had to consent him. And I remember that as bad a boy as he was, his mom and his grandmas and grandpa were there. And their one concern in all this calamity of life and death was whether he could be fed. And they held on to that piece of hope with everything they had because they felt that they were offering something. They couldn't control anything else. They couldn't, all the other nightmare stuff that was going on in the ICU, they really couldn't impact, but they could impact this. And it really taught me a lesson regarding, one of the lessons I've learned in life regarding the impact of nutrition in general on families, irrespective of who you are. So let's talk about this. I'll give you a little historical perspective. So when I got asked about this, I said, okay, I can do this, but let me do it by history, give you a historical perspective. And I'm not going to show you all the stuff, but you've seen photographs. I've been to these meetings before, and I've seen all kinds of nightmarish photographs. So this is nothing new. But to say, putting in a feeding tube is a procedure. But historically, there are things that we have walked through, just to give you a little idea about where we have come from. So back in the early days, this is from 1990, there was actually questions about whether feeding tubes put through the skin surface percutaneously made any sense long term. Maybe it was too invasive, and maybe we should just have people have nasal gastric tubes or nasal small bowel tubes, and that's fine. I'm not sure they checked with the patients on that. But there were studies actually performed to consider whether there was a difference in clinical outcomes. And we physicians talk about clinical outcomes, meaning what happens and complications and things. But one of the things we generally don't capture is the patient's outcomes, meaning their quality of life, and that is a tremendous impact. And we've moved well beyond this now. And so when we talk about a feeding tube today, I'll give you some nomenclature. There's a series of things we talk about. They're all listed here. But one of the things that I pay special attention to is somebody's functional status. Let me tell you what I mean by that. It's how good is their quality of life at this point? And it comes from lessons I learned in the disease state of dementia. So dementia, as you know, if anybody here has had a family member with dementia, as you progress through that disease, the very end stages, in addition to everything else, is you lose the ability to swallow. You lose the coordination to swallow. And therefore, you can't swallow, and so food will sit in your mouth, and or the patient will accidentally suck it into their lungs, which we call aspiration, which, as you all know, is not a great thing. And so there, as a gastroenterologist, I can remember many times I'd be called into the room where the family doctors had already discussed and the family had made up their mind on a patient with dementia that, look, they need a PEG tube or a feeding tube. And then I would come in and three things are going through my mind. One is, this is not a great idea. Two is, my colleague has already discussed this with the family. I have no relationship with the family, zero, because frankly, I'm a consultant. And three is, the families discussed all this ahead of time, right? I'm sure there's been some huge discussions about the right and wrong of what to do, and invariably there'd be somebody who hasn't been involved in family decisions who will come flying in from some state somewhere, feeling guilty because they haven't spoken to their mom and dad in 3 years, and then all of a sudden they want to have a big imprint on what's happening. So what it taught me, though, is that there's no sense in doing things for people without consensus, but the consensus has to be very transparent. And that goes into the decision-making process. We talk about this today. And also point out that what I call institutional expertise is important. So for example, at Buckman's institution, there may be somebody who's very good at putting in a feeding tube, and at Dr. McCallum's institution, it may be somebody different. But what I can tell you is putting in a feeding tube is not the end of the story. That's called being a technician. You should search for, as a patient, those people who actually care for you after the tube goes in, because that's when the issues occur. And if you have an issue, finding the person who put the tube into you for care, that's a problem. So institutional expertise is beyond having the ability, it's having the systems in place to follow up and provide the care that's necessary. For example, I wouldn't do a heart transplant and then say, have a good life. I probably would see you afterwards to see how you were doing, because I have the expertise in doing a heart transplant. Not that I do, but you get the picture of what I'm trying to say. So when we talk about nomenclature, I'm not going to bore you with all this, but there's 3 types of physicians who are involved here in general. There's the gastroenterologist, like myself. So I can use an endoscopy, an endoscope. Most of you have had an endoscopy or a colonoscopy. If you haven't had one, you're over the age of 50. Talk to me later. But frankly, that's a gastroenterologist. We put in PEG tubes, percutaneous endoscopic gastroscopy. If the tube ends up in the small bowel with an endoscope, we call that percutaneous endoscope jejunostomy. That's the small bowel. And if the tube goes through 2 structures, the stomach and small bowel, together, we call that percutaneous endoscopic gastrostomach jejunostomy. Makes sense, right? Pretty simple. If the surgeon does it, God forbid, no, the surgeon does it, then we call that the surgical gastrostomy, stomach, surgical jejunostomy, small bowel, surgical gastrojejunostomy. Get that? Makes sense. And if the radiologist does it, then we call that a radiologic gastrostomy. Some people call it a RIG, radiologic interventional gastrostomy. Too fancy. Radiologic gastrostomy, radiologic jejunostomy, radiologic gastrojejunostomy. So basically, the first part of the word is who puts it in, which should help you identify the person who should be caring for the tube. The other thing I would say to you is the gut is pretty simple. Actually, it's simple, but it's complex. And so, when we've been hearing stories today about the stomach and the jejunum, which is the second part of the small intestine and the colon, we base all these. You typically don't get a PEG tube in your colon, right? Because your colon doesn't do a lot of nutrient absorption. There are reasons, actually, you could get a PEG tube in your colon. We could talk about that later on. But we tend to use the stomach or the small bowel, and I call it the hierarchy of feeding tubes. And I'll tell you what I mean by that. It's a very simple decision-making process that we run through from this perspective. So just as a little historical perspective, this is a feeding tube with PEG. See that piece on the very end there? I hope this has a little, right here? So that's the internal bolster. And most everybody, if you have a PEG in this audience, you have one that can be pulled out at the bedside, meaning you pull the tube and it collapses and you remove the tube. But there was a day when these internal bolsters or bumpers were rigid. So you could pull all you wanted, it wasn't coming out. And they were designed to keep people from pulling them out because there was a thought process that was not good. But you needed to have another procedure. And all I would say to you, these still exist. And so it's a good idea for the clinician and the patient to know what kind they have. So when they're removed, we can remove them appropriately. Surprisingly, you'd be surprised how many people walk in to me, new patients who don't know. And so that would be an issue. This is what Dr. McCallum was talking about. This is a gastrojejunostomy, so this is a PEG tube that's in the stomach. There's a small bowel feeding tube that goes down to the small bowel, gastrojejunostomy. There's an opening, see this little opening here in the stomach? So you can put medications in the stomach or maybe decompress, and then you can feed through this tube down into the small bowel, percutaneous or surgical or radiologic gastrojejunostomy, 2 tube systems. The J tube does have a problem because it can get displaced backwards, as been mentioned, but it's good, it's great for some situations. And then this says Vivanex. This is just historical because Novartis one time owned a product called Vivanex tube feeding. And they branded their product, their tube feeding product, with this little surgical tube. And the surgical tube here was a little tiny needle that went into the small bowel, with the thought from the surgeons being, wow, if I just make a little tiny hole, that's good to feed people. The problem was that they fell out. So we don't tend to see these anymore. This is the small bowel. From what you had heard today, this is actually a PEG tube in the small bowel. This is something a gastroenterologist can do. So if you need a jejunostomy, it doesn't have to be placed surgically. A gastroenterologist can put one in with an endoscope if trained. But these are a combination of all sorts of different manufacturers' J tubes put in by a surgeon. The reason I'm saying that is all of these are placed in, but you notice that they don't really have any great fixation devices inside, so they tend to be sutured to the abdominal wall initially. And they tend not to be tubes that have balloons on the ends, because there is a premise that if you inflated the balloon, then you obstruct the lumen and the patient gets small bowel obstruction, right? Not a great idea. Or perhaps that they would fall out if the balloons burst. But surgical jejunostomies, by and large, when they're initially placed, are sutured to the abdominal wall by some fixation device, and then later on they're exchanged out for a different type of tube. So you can have a lumen, you can, what I was showing you there, the PEG tube, you can put a tube in a small bowel that has a big lumen, or you can put a tube in a small bowel that has a very, very tiny lumen. So when I think about gastric access, this is to Joan, who was saying right tube for the right spot, eliminating the rectum from consideration today. Typically, if you have the option and the stomach works, that's what you're going to use for your access, because the stomach's very forgiving. It doesn't mind being poked. The fact is, that's how you normally eat. There's the gastric pacemaker that's in the stomach, which contracts and sends a message down to the rest of the gut to move things forward. Things are released from the small bowel over periods of time, not all at once. You don't just have a large volume of stuff just go winging down into the small bowel. You don't eat a cheeseburger and 2 minutes later it's in your colon. It's digested and little pieces and parts move out. And so preferentially, if we have to use access, we want to use the stomach. It has a huge amount of advantages as compared to small bowel access. And also, many of you'll hear about enteral feeding from Carol. I don't know if she's getting into delivery mechanisms, but I heard about it all yesterday, is the fact that, if you want to do bolus feeding, I heard somebody in one group is putting in 1,100 cc's in 2 minutes. Yesterday, I was like, holy cow, that's unbelievable. They should be on like Man versus Food, from that perspective. Or continuous feedings, right? If you don't want to do bolus feedings. In gastric enteral access, here's some of the common things. I'm not a big believer in it for dementia, except for people who have an intact quality of life and functional status. But there's some other things. But the thing here is most of these are swallowing disorders. I can't swallow, or something's wrong with my esophagus. It's not that something's wrong with your stomach. Something's wrong on the proximal GI tract that we get these. In deference to a small bowel feeding tube, where for whatever reason the stomach's not working. We heard from Dr. McCallum about gastroparesis a little bit. Some patients may have had their stomachs removed for gastric cancer. Or if you've had esophageal cancer, when they do that surgery, then they take your stomach and they move it up into your chest, right? It's very hard to put a PEG tube through the chest wall to get to the stomach, so we tend to feed into the small bowel. Or perhaps you've all heard of pancreatitis. Some people will have pancreatitis, even chronic. There's a thought, I say a thought, that feeding into the small bowel for pancreatitis is better than feeding into the stomach. So there are reasons this. And one that's not commonly thought of, but it exists, is somebody with reflux and aspiration, meaning somebody who, frankly, has a big issue with gastroesophageal reflux or stuff from your stomach ending up coming up into your esophagus. You lay down, you're sleeping at night, and you aspirate because you're asleep, or if you lost your cough reflex, which is another large indication for small bowel tubes. They, by and large, small bowel tube feedings, as I mentioned, can be used put in by a surgeon or a radiologist or a gastroenterologist. Check your center expertise. However, do not settle for somebody who puts it in and walks away. That is not what you want. You want somebody who's willing to see you afterwards to make sure that whatever problems you may be having or not, that they're able to handle those problems so you don't have to sit home and wonder what you're supposed to do next. I'll also say, just to tell you that as a gastroenterologist or surgeon or radiologist, we look at x-rays. I just thought I'd show you this because it's kind of fun of an x-ray. So here, can you see this black area here? Do you see that there? That's your stomach. So there's a feeding tube that's in the stomach. And then I know right here is where your duodenum is, right in this area here. And I can see this is a GJ. Here's a peg tube, this big, looks like a garden hose here, for better lack of words. Then there's a thinner tube here. This is the J tube. I know I'm going around the loop of the small bowel, and then I'm coming up here, and then I'm ending up here. I just know from experience that I'm sitting here in the jejunum. So we do look at x-rays frequently for, especially with J tubes, so we can know what their position is. Hence, it's good to work with somebody who looks at x-rays so they can interpret them when they're looking at a complication that may be developing with a tube. So in conclusion, here's what I would say, and again, don't have a rectal tube. I'm not recommending it unless you really, really need one. That's my first conclusion. Second conclusion is that for both small bowel and gastric feeding or stomach feeding, there's a huge variety of commercial options. We've all heard about those, and you know better than I do. We haven't even talked about low-profile devices. That's not the purpose of this talk. But knowing what's available is important. And if the person you're working with doesn't know, encourage them to find out, or here's the message, find somebody else. The second thing is that I'd rather feed into the stomach as compared to small bowel because it's more physiologic. That's how we were designed teleologically through history to eat. When I'm choosing a tube feeding formula, that's not my talk. Carol's going to talk about tube feeding formulas, but I do have more choices for tolerance when I'm feeding into the small bowel than I do, in the stomach as opposed to the small bowel. And then for gastric feeding, I can bolus feed or continuous feed. Now, I say that, and someone in the audience is going to raise their hand and say, I'm a small bowel guy or girl, and I bolus feed into my small bowel. And I would say to you, fine, that's fine. I'm not saying you can't do it. What I'm saying is there's a number of people who can't tolerate that. It's not an option for most people. And then lastly, my message is with tube feeding, which tends to be often in patients with swallowing disorders, we forget all about reflux and aspiration, and it can be a real definitive reason why I may decide to move from gastric to small bowel, given the limitations, because I don't want someone to have problems with reflux and aspiration. That's it. Thank you very much.
Thanks, Mark. Now that we know what road we're driving on, we need to know what kind of car we're driving. So the next speaker is another one of my colleagues from UIC, Carol Braunschweig, who's a professor in the Department of Kinesiology, and she's going to speak to us about the type of enteral formulas that we need to use, choosing the right enteral formula. Carol?
Okay. How many of you all are on enteral feedings, receive enteral feedings? And how many of you all pay for them out of your pocket? Most of them have insurance cover for most of it? Okay, so I've kind of geared this, I'm just gonna give you sort of the nitty-gritty about how if you were out in the woods and had to do this yourself, how would you make it simple to be able to pick what you needed to pick if you, just sort of the basics of what we do when we're prescribing or administering home enteral nutrition. So it's this one? Yeah. All right, so we know that there's about 430,000 individuals in the US that get enteral feedings at home. So there's a lot of you, okay? Some for a long time, some for the rest of their lifetime. And For the last about 40 years, which really encompasses my entire time working in the field, commercial formulas, we didn't used to have them. We used to make, when I first entered the field, and I'm not kidding, we used to make the enteral feedings, many of them, out of baby foods. And we'd make them up in the kitchen, and we'd put them in little containers, and we'd design them tailored for the individual's needs based on how many baby meats, how many baby fruits, vegetables, and we'd rotate it through. We'd label it according to sodium and protein, and we'd make them up, right? And then along came commercial products where they were more able to put these things in cans, and we'll kind of walk through that. And with that came a number of real nice things. It's safe. It's absolutely, they're completely sterile, so you don't need to worry about contamination. They're in nice, easy 8-ounce containers for the most part. They're easy to administer. You pop the top, you put it in your bag, and you call it a day. And they're designed to meet your needs, because there's many of them to pick from, in the volume that you need. So they're quick and dirty, and not dirty, they're quick and clean and easy for you to do what you need to do, which is not particularly fun, given that tube feeding. It's not something that you want to dwell on. It's not like outside gazing at the stars. So it takes something that is sort of part of your drudge of a day and makes it into an easy part of the day. So today what I'm going to start with is, how would you go about looking sort of in this vast array? Let's make it simple. How do we go about picking a formula for you? And then I'm going to go into a little bit of what's sort of coming now is this use of blenderized food to make your own formula. We'll touch on this, and I know you have a longer time. I just sort of introduced it, and you have some more time that's going to delve on this later on this afternoon. Okay. So what are enteral formulas? Obviously, they're a liquid mixture that are composed of carbohydrate, protein, fat, vitamins, minerals, and water, and electrolytes in proportions that mimic a balanced diet. And they're designed and many times for a specific disease. So depending on what you've got going on with you, they can pick a formula that's really tailored to meet your unique medical nutrition therapy. That's the terms we in the RD world talk about. Sorry, I gotta go back. Now, whatever your energy and protein needs and water to a certain extent, this is going to determine your daily volume that you need to get of your formula. So just like for anybody that's not on enteral feeding, the amount of calories you need a day, calories, or kilocalories is more accurate, but calories, the amount of energy you need to eat in a day to not lose weight, to maintain steady, is determined, well, obviously, by your energy and protein needs, okay? So we do the same thing with enteral formulas, only now I'm saying it's just the volume of the amount that you're going to give a day that's going to determine that your energy and protein needs are going to dictate this. Okay, so so the first thing then, obviously, that you're going to have to do is determine what yours calorie and protein needs are. And these are established for healthy populations by the National Academy of Sciences. About every 5 years they update these. But they established by the experts in the United States, which therefore really when it comes to these kind of nutritional aspects of care, these are the experts in the world that are determining and modifying over the years, how do we determine what Americans, based on a population sampling of Americans, what are their energy and protein needs? This is based on your age and your gender and your activity needs. Now, for enteral feedings, it's also tailored for your unique medical needs, okay? The RDIs are just established for healthy populations. We extrapolate from that. We RDs and physicians look at what are your needs based on what you got going on medically. You may need more or you may need less, depending on what's going on with that. So I just put this up here for ballpark figures. So it's 28 to 34 kcals per kilo. There's 2.2 pounds in a kilo. So that's 13 to 16 kcals per pound. Okay, so just if you take your weight in pounds right now and multiply it from that, that'll be sort of about ballpark, no guarantee. It depends, once again, we modify it by your age and your activity level, but there's no point giving, I always call these things rules of thumbs, hangers that you can sort of grab onto so that you can at least get some kind of number to start to make sense of something, because otherwise it's infinity, and human beings can't even get their head around infinity, so I want to give you something to put your hands on. So this is very rough. Don't hold me accountable to it if you lay outside of this. If your physician or your dietitian tells you, no, that doesn't fit, she's an idiot, I put a caveat around this that says you may. So a 70-kilo man or 154 pounds needs somewhere between 1960 and 2,380 calories. Just another ROT, rule of thumb, that I work with. Most human beings in America are not really physically active. About 40% of us are obese. And generally, the average, not real elderly and over the age of 18 needs probably, determined on your height, weight, and gender, obviously, somewhere between 1,500 and 2,800 calories, okay? That's not that large of a range. So that's a pretty narrow range. However, a little tweaking each day, especially in enteral feedings, if you're just a couple hundred calories over or below, you're going to lose or gain weight. And generally, it depends where you're at in your spectrum with your enteral care. They may want you to gain weight to help replete from where you were at, or they may actually want, if you're overweight, they may want you to have a gradual amount of weight loss. So yeah, you have to take that into consideration. And the younger you are, the more active you are, the more calories and protein you're going to need. All right. Now, I mentioned water in the first slide. And how much water, this gets all the lay press. Oh, you got to eat 12 glasses, 8 glasses. How many cups of water do I need a day? Well, the good news is you and I have this magnificent control called thirst. So, and you felt it yourself. If you maybe have done a run or something, you've been really busy and you haven't had anything to drink, and then all of a sudden you freak out and you think, I got to have something to drink now. And then when you're kids, we used to drink like a quart of water real fast, and then we'd lay on the ground and one girl would put their head on the other one and we'd wiggle, so you could wiggle your stomach. But the magnificent thing is, you feel when you're thirsty. The sad part is elderly people lose that sense of taste, and certainly if you have a medical condition where you're not able to discuss it or you can't get to free water, it's not going to work, so you can't depend on it. But for those of us in the audience worrying about how much water we need in a day, really that thermostat is set very tightly. Just tiny little degrees your blood gets a little more concentrated when you get a little dehydrated, and you shoot off all these hormones that say drink, 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 and you will. So it's nicely tied. Not to say that there aren't conditions where it can get untied. But this is one recommendation that's out there that's used, that I just give you for your edifications if you want to put it in your file somewhere. And then I took it down into English, the way we don't use ml. Maybe you guys do, it's because you're used to doing enteral feedings. But most of us think in quarts and rather than liters, and we don't think in mLs, we think in ounces. So roughly, a liter is 1,000 milliliters, is around 34 ounces, is about a quart, okay? And then I just have a kilo is 2.2 pounds, and then so that you can decipher all of these things. But essentially, if you go down to the bottom where it says, if you're an over 70 kilo person, it's about 2,500 mLs, okay? So, but this is just the precise way of how we go around doing it. So, all right, so I've said first you do calories. Protein is generally somewhere around 1 gram of protein per kilo of body weight, okay, roughly. And you divide your weight by 2.2 to get that. So, how do we make sense of all of this? Well, it turns out that the commercial formulas are divided by how many calories per ml that there is in them, okay? And essentially, there's these 4 major categories of formula. Now, you can envision that the more concentrated the formula, i.e. as you go from 1 to 1.2 to 1.5 to 2 kcals per ml, there's less water in it. Because what do? They take the water out. Water doesn't have any calories, any protein in it. So they just concentrate it. All right? So what I have on this slide is the different types of formulas. This is not an exhaustive list. That would have taken a couple of pages. But it just gives you how many, what it's made by, and a couple of examples of formulas that are in there. Each of these formulas, they all contain the number of kcals per kilo, or per ml, that are listed here. But they have varying amounts of protein per liter. They might have varying amounts of certain kind of, whether or not they contain some fiber, whether or not they contain, how many total mLs in a day it takes to get your vitamins and mineral needs at the recommended dietary intake level, okay? So this is just sort of a way so that you can organize how we look at formulas, which has to do with how many kcals per ml. So, as I promised, the amount of water in any one of these formulas is determined by the amount of kcals per ml. So that a 1 kcal per ml formula is about 84% free water. So if you get a liter of a 1 cal per ml formula, you'll get 840 mLs of water, not a liter. So we look at the free water that's in here. Now this is really important if you're taking care, as I said, if you're taking care of somebody that's perhaps comatose, can't express themselves, can't detect that they're really thirsty, you would dehydrate them. Actually, in my previous job before I came to UIC, many nursing homes, I was from Michigan, and many nursing homes in Michigan in the summertime, especially up above the middle of the mitten, don't have air conditioning, especially if they're Medicaid. Especially if they have very low funding. So these people would get really hot and sweat more in the summer. And so we'd have a lot of dehydration cases that would come in because their formula rate would be set and they couldn't express themselves. And so they'd come in with acute dehydration. And then over a couple of days, we'd rehydrate them up. Okay, so that it can happen if you're just looking at the volume and thinking that's how much water they're getting, because it's not all water, obviously. If it was all water, it wouldn't have the protein, carbohydrate, and fat, and vitamins and minerals that you need. So that in 2 cals per ml, in 700 mLs, it's 70% water, so you're only getting 700 mLs of water. So just keep that in mind. Let's talk a little bit about fiber. Fiber is, commercial formulas for years were devoid of fiber, and to this day, the fiber that they have in them is not so red hot. So when we talk about fiber, we talk about soluble and insoluble fiber. If the slide after this shows you a slide that shows you the percentages of each one. Soluble fiber, what it does it retains water, and it gives the stool like a gel-like formation, and it slows absorption and food passage, which many times, especially with diarrhea, that's a good thing. Insoluble fiber speeds up passage of food through the stomach and adds bulk. It makes your stool weigh more. So you've got heavy bowel movements. Yahoo! Okay, so, and when we talk about this in health, it's usually the soluble fibers that help with cardiovascular disease when you're trying to get cholesterol levels down. Those are the good fibers. And the insoluble fibers are for things like diverticulitis, when you're having constipation issues, hard stools or loose stools. But really what we get in full diets, in the diets we eat, is a mix of these things. In nature, we don't get a diet that's just one soluble or insoluble. In fact, it's always a mix. Okay, so oatmeal is a good source of soluble fiber, but there's some insoluble fiber in it too. But in commercial formulas, they really have to have almost all, 74 to 100% is insoluble fibers. Why? The soluble fibers attract the moisture and expands the formula, so the bag would blow up, so they can't add it. So the commercial companies say, we've got fiber, and they do, but it's only one kind, and it doesn't really exist in nature like this. So this is sort of a downside, and it doesn't add the complete or comprehensive health effects of the fiber in the diet that you eat from a wide variety of fresh fruits and vegetables and whole grains, okay? It's not a bad thing, it's just sort of the thing. All right, so where am I at with my time? I think I'm close. I've got a little bit of time. Okay. Okay, so I want to just go now so here's what's happened. How many of you guys have talked to or worked with or thought about doing a blenderized feeding? Okay, and do you feel comfortable with it? Did you work with your dietitian? You just decided you wanted to do it? Well, come to find out that this is a thing going on. And in the hospital setting, we're really not wanting to do this because of the safety issues with keeping it clean but as I said, dial back to 1980, and that's how we were making a lot of our tube feedings, was from basically blenderized baby food, right? Well, what's happening in America today is because So to talk about taking a vitamin and mineral today and thinking that that makes you have a healthy diet is really retro nutrition. We nutritionists think like, yeah, that's so yesterday. That's like these 18 nutrients that we know there's an RDI from. Food, in fact, is loaded with micronutrients that we don't even know. It's like an orchestra hall filled with micronutrients that interact together. Many of the things we haven't even named yet, let alone the composition and how they work together. But we have firmly established that a wide variety of foods spread throughout the day is what makes people healthy. So we can't name everything in it. We can't put it in a pill for you, but we can package it in a wide variety of, turns out, brightly colored foods is really a wonderful thing. So, of course, this is our message to all the public health, is eat a wide variety of fruits and vegetables, a diet that's moderate in saturated fats, blah, blah, blah. So everybody that's home says, well, what's this can? A commercialized, processed, wow. And you know, as a nutritionist, I hear your pain. So there's this movement going on to making blenderized foods. And some companies are getting into doing this. There are some packaged things coming out with this, and I'm not sure of the price. I've not looked into it. But the idea being is, look, we know that now especially your gut microbiota, you really are what you eat. And the bugs in your bowel help to make so many things, from how you sleep, all kinds of things work, from circadian rhythms to neurovascular, all kinds of mental status things get influenced by the food that you expose your gut to. And there's these probiotics and prebiotics and a wide variety of a diet that's widely varied helps to fuel the good bugs in your bowel. And we love our bugs in our bowel. We don't function well without them. So there's a lot of people that say, hey, I want to use real food. It's time. So I just thought I'd present a couple of little things. And these are just pros and cons. The pros of blenderized tube feedings, it's diverse whole foods, promoted that you can provide over 24 hours, but it takes time. It can be and it can be costly, and you have to rotate for preparation. There are some good things. There have been some reports, although it's not widely reported, and I can't say that it's a given, in improvement in GI symptoms with it. There has been some reports of improvement in blood sugar, but once again, this is not by all means a given, and the studies. This is not. I am not up here saying that these are truisms, but these are, let's just call these case exposures. People are claiming. You can look through these, but basically the main thing, that the risk that we in the healthcare, especially in hospitalized patients, is infection risk. Because every time you're prepping it at your home, especially if you're not under the care of somebody helping you with recipes to get them widely varied and the way that you prep it is clean, is you can introduce a lot of problems. So you really, if and when you decide you want to do this, you should work with your enteral feeding company with a dietitian to help to work this out. So there's a lot of ways to do this. You don't have to start all or nothing. It's not binomial, okay? You can do blenderized tube feeding only. That's certainly one option. Or you can use it with some commercial formulas, okay? Or you can do some tube feedings a day, or you can use it as a backup. So or any kind of mix thereof, whatever it works for you. So what I have here are, let's just talk about foods. The prep of this is absolutely essential. Remember, many of these patients you guys on home enteral feedings have depressed immunologic profiles, all right? You don't fight bugs well. And so any kind of GI bug, other people that don't have this compromise might fight the bug very easily, whereas you guys wouldn't. So it's really imperative that you wash everything. Hand washing, soap and water, wash hands for at least 20 seconds, air dry, or use a clean towel that's only been used once. Wash counters and cutting boards and strainers, wash the blender and the rubber seal, the cans, the tops, and the fruit. When you prep it, any kind of product, animal product, meat, fish, or poultry, cook it to the right temperature. It should be thoroughly cooked. Don't do medium rare meat beef in your blenderized feeding. Keep any utensils that you're using for fruits and vegetables separate. And bacteria from raw food can make cooked or fresh foods very dangerous. So how about storage? After you make it, you can be stored at room temperature for 2 hours, okay? Just 2 hours, that's it. You can refrigerate for up to 24 hours, and you can freeze it for up to 3 months. So it's not something that you cook and you just leave out there, because that's a setup for bugs to, life begins at 40, so temperatures that are above 40 degrees or below 140 degrees, that's where bugs just flourish, and so you really don't want to let that food sit out on your counter. So thaw it just like overnight in the refrigerator. You can mix with the blenderized with commercial formulas, and don't add newly prepared blenderized formula to older prepared blenderized formula. And then I've just given you a couple of recipes here. This is for an adult, and it has 500 calories and 25 grams of protein. It sort of just tells you this is one that's been used for kiddos, and it tells you sort of how to make it and how to do it. But there's another lecture on this. And then finally, just because I thought I had to include these addresses, there's some information for anybody that might have food allergies, and then I've gone through different formulas that are best for those that are different kinds of formula-free, which probably if you have food allergies, you're already hip to. That's all I've got.
Okay, we're going to open this up for questions, and it's kind of interesting. At lunch is actually coming soon. We have one session left after this, so it works out well. Maybe you can take some of those things home, stuff them in your purse, and grind them up and try them in your tube. Let's start with our first question here at the microphone.
Hi, this is for the dietitian. I know you're not going to readily be able to dispense medical advice. We are on the cusp of this whole EOE diagnosis, which really makes real foods difficult to introduce. I know the theory is that if it my son is enteral fed, if it bypasses the esophagus, there can be less risk. And his last scope was perfect, but he's on all the treatments. He's on the enteral formula. I'm sorry, he's 9. He's on the Elecare. What is that called again? Elemental, thank you, elemental formulas. But a lot of his GI system seems like it would benefit from some of this real food blends. And so with people who love us, we get some pressure, not negative, but some pressure like, have you tried the real foods? Have you tried the real foods? The idea of living on corn syrup solids for the rest of his life doesn't feel real good. So we're trying to sort out, like, how do we do what's best for our human who will eventually grow. And now we're walking down this autism road, and you and I both know that your diet can affect so much, and so we feel like we're not getting the help that we need at home, and people look at us like, no offense, sir, but we feel like when doctors don't know what they're doing, they just kind of look at you like you're the problem. So, can I get an amen? Okay, so we feel stuck. We don't feel empowered by our physicians. We feel like our dietitians are pretty much under the control of the doctors. So to try and have an open, honest conversation, I feel in this country is like impossible.
So the concept, let's just start with the food issue.
Yeah.
Number one, when it comes to dealing with any healthcare issue, I think we all feel terrified when we're trying to navigate the fields in areas that is not our area of expertise. So if I broke a bone and I was in with an orthopedic surgeon, I'd be freaked out too. So I think that's and then if it was my child, I'd be over the moon. So I think that's a perfectly sound advice. Let's talk about your child right now. He's 9 years old.
Yeah, male.
So I'm imagining that you're working with a GI person about his esophageal issues.
You just scope him and say he's fine, or scope him and say he's not. And because he's already on like the EOE treatment, there's really nothing to do.
Yeah. And elemental feedings are so disgusting.
He doesn't have to drink it.
Yeah. But to go from an elemental feeding to a full food feeding would be not something I would be able to advocate. However, he's 9 and his physiology is changing all the time as he grows and does. So I can give you a name. There's a dear friend of mine, Bethany Dorfler, who works with GI patients down at Northwestern, just exactly like this. So I'm happy to give you a name and a consult number that you can call, and she can start to talk to your doctor as well. But on your own, the best meaning aunt, uncle, mother, sister, brother, whomever that starts to talk to you about spiritual value of food. I mean, to literally get in that route with you.
Yeah.
you can't, you've got a different gig going on with your son. So I wouldn't jump into it. You do need advice from your physician and from the dietitian, and I really do have a dear friend who's an expert in doing this and working with physicians on this who will be able to navigate it for you.
Okay, perfect.
So let me just take that on too. So
thank you.
Does your son have EOE and has symptoms from EOE? Meaning
he did when his eosinophils were like at 13 on Prevacid.
So I'm going to go on the line, out on the line here as a gastroenterologist. Okay. First of all, EOE, there are a number of new pharmaceutical treatments coming that are in FDA evaluation now. So I'm just telling you, it's an autoimmune disease. So, you know, that just like Crohn's disease or inflammatory bowel disease, you'll have to look at those options. Food is an important component, but there is hope coming from that perspective. The second thing I would tell you is I'm not aware of any data that suggests that an elemental diet, any prospective randomized trial that's shown that an elemental diet is preferable for EOE. I keep hearing this. I'm not quite sure where that data is coming from.
Oh, it comes?
Yeah. What's that?
It comes from the physicians.
I get it. I'm not being deferential to my pediatric colleagues. I'm just saying I'm not aware of anything. And the third thing is, look, as a gastroenterologist, but with a fervor for nutrition, I think there's a lot of issues you're going to have to take a look at. And going to a regular diet, looking for an elimination diet to try to figure out what the culprit is, if you could ever do that, is going to be nearly impossible. I just don't.
It's really hard. It's kind of like when you're introducing food to a newborn, a 6-month-old or
what I would say is, there are going to be products that'll come out that'll be low allergen, non-GMO based. And you have to think about chemical hypersensitivity, all the things that are used in manufacturing, preservatives that could impact commercially based tube feeding. So keep your eyes and ears open because there are answers coming for that.
Okay.
Okay.
Right. Thank you both.
Of course, the question is: are the blenderized food people today just the juicers reincarnated? Are they the juicers reincarnated? The people that were all the classes on juicing, and now it's all how to make.
It's one and the same thing. Really, truly, I was a blenderized tube feed maker in 1980. I made them at the University of Michigan. We'd tailor them for people. That's how we did it. Baby food, baby meat, how much baby beef, how much baby veal. Yeah. So
let's go to this microphone over here.
I have kind of a combined question, and I'll back it up with, I was the mom that fought for my child to have breast milk through his feeding tube. We also blenderize because I gave birth to a baby, not a textbook. So my question is, I have a love-hate relationship with dietitians. A love-hate relationship with dietitians, but you seem cool. Maybe you tricked me. So really what I want to know is, in working with a gastroenterologist and the dietitian they typically have on staff, how can I, as a parent who hates the day I get told, oh, we're going to do a week-long dietary study to see what he's eating. It's like asking a parent of a one-legged child, let's see how fast they can run. You're asking me to document something when we have no control over a system that doesn't function properly. So how can I, as a parent, help make your job easier, but still be a mom?
Okay, so I'm going to tell you a truth story. I was in my PhD program, and I had a dear friend who was looking at something that required people to keep track, us, to keep track 7 days of what we ate. She was a friend. I was getting my PhD in nutrition. I knew how to do every aspect of nutrition assessment. And by the middle part of day 3, I was making up what I was writing down. Now, that's true because it's impossible to do it. And then when you ask someone like you to do it, the capacity that you can do it any more than we adults can do it, these are all things that we take into consideration when we do assessments. So I think having an open and honest dialogue with them saying, I can't do that. I can come close. Here's what I think I can do, I think is very fair. And I just do. That is exactly what I would do if they'd ask me to do that with my child. Because, I mean, I don't know how old your child is now, but it's hard to do. It's really hard to do.
I laughed when you said you guys use milliliters, because that's the biggest thing we always run into. And I'm like, you went to school. You can do the math.
Yeah, yeah. Yeah.
I'll give you the numbers. Go ahead and convert it yourself.
Yeah. So what they're trying to, I guess what I would want to do is say, how can we do this so that I can meet the needs you're trying to get me to achieve? How can we get to what do I absolutely have to do? And is there a way I can call this in daily? Is there something you can do to facilitate me? Because I think thinking, see you in 7 days, in the meantime, chalk your life to doing this may not be in the realm of the reality of what, I don't know if you have other kids or a job or any other things that you have going on in your world other than watching this child. It's tough. So that's my off-the-cuff response. And I think that as a client of mine, if you were to say that to me, I would say, all right, let's do this. You're going to work out texting, work out things we can do that you're capable of doing to come to the best possible way you can. There's a lot of ways to get to this stuff now that there never was. And we work with this with studies that I'm involved with how to get what people are eating. There's more ways now than there ever has been. So we don't need to go back to this old record with a pencil and a paper and having you keep recording and be visually over them. So it has gotten a lot better. So I try to work with them on that, first and foremost.
Thank you.
Okay. Next question.
Hello, this question's for Dr. DeLegge. I'm Tammy, an oncology dietitian in Champaign, Illinois, and most of my practice has been inpatient clinical, but I've been on the outpatient ambulatory for a few years now. But my question is regarding the placement of the different feeding tubes. Since I've been on the oncology side, I'm working with a lot of head and neck cancer patients, and so the preference is to have all the tubes placed through interventional radiology. In the 2 years that I've been working on the outside, I'm just seeing a lot more issues with the more temporary tube placements, a lot more leakage, and just more issues overall. So I actually have been working with wound care a lot, with just trying to manage some of that. Yep. So I guess my question is it realistic for me to push for digestive health to place some of those? I think the thought is they don't want the scope going down.
I got it.
Through an environment where they could risk spreading those cells.
It's a great question. So let me answer it and simplify it for everybody else a little bit. So head and neck cancer is in the back of your throat. You have a cancer in the back of your throat, and there's some data to suggest if you do endoscopy, you go this way, the feeding tube goes through your mouth and down and comes out your abdominal wall. Comes out your abdominal wall, and that some of the tumor cells can get caught on the feeding tube, and as it comes out your abdominal wall, it can make the tumor move from the back of your throat to the abdominal wall. Does that make sense? Okay. Although the incidence of that, I got to tell you, is pretty darn low. Okay. So here's what I would say is, I get it. My experience is know your institution. If you're an interventional radiologist, and I got to say the IR procedures for placing feeding tubes are not, I'm going to say this as a gastroenterologist, and so I'm biased. I don't think they're as good as the other ways we put in feeding tubes. Having said that, if your IR doctor is good and committed to this, then they should be following up with these patients and dealing with the complications and addressing them and be comfortable with that. If they're not doing that, that's a problem. So I've said that a couple times today. The other thing is that there are ways endoscopically to prevent from translocating the tumor cells. I could talk to you offline about that. It's very simple, something that I instituted in our practice that prevented it, something that most gastroenterologists could do very, very quickly.
Okay. I just didn't know if it was realistic for me to push. Our digestive health certainly has a much longer waiting time period for placement of tubes, which has also been an issue because a lot of times we want them prophylactically placed after bilateral treatment.
I got it. And here's what I would say is getting the tube's important, right? But the stuff that happens afterwards is as important. I mean, you can get your car fixed by someone who doesn't know how to, who can get it on the schedule, but frankly, when you go back to them, they disappear.
Right.
That's all I'm not saying I'm not castigating anybody specifically. All I'm saying is you want to go to the person, whoever they are, that you can get in, get the procedure done, but also is prepared to do all the work to follow up with the patients later on and address the issues, because this is not a one-time procedure. This is a procedure you're doing with a patient that has ramifications for a very long time.
Okay, we have time just to take one last question really quick and a quick answer.
Oh, well, I have questions for both of them real quick. One for the GI doctor. I know FDA approval obviously takes a lot of time. But is there any, as far as you're talking about like EOE treatments that are coming down the line, is there any approximation when you think that is going to be known to people?
I can tell you there are 3 trials ongoing now. One of them, two are phase 3 trials, so that's good. Meaning when it's phase 3, that means the next part is, so I would say you should see something by about 2021.
Okay, so in the next couple of years, probably there's going to be something.
Yeah,
coming
I mean, I'm
That's
assuming
great.
the trials are successful. You know what I'm trying to say? That
Right,
But,
right.
yeah.
Assuming it all goes well.
Yeah,
That's what I'm. So okay.
So thank you, Carol, Mark, excellent. So as we wrap up this morning's session, we're going to do it in true Oley style. We are going to showcase just 3 examples of how we are so inspired by some of the consumers who have managed to get beyond situations and move on in life for different reasons. And we have some very well done videos which really kind of walk you through it. And we have the stars of those videos with us. So at this point, I'd like to bring Mike Sherels here and Sherels, oh, sorry. You've been Sherels for a year, and all of a sudden they try to get me to, so Cheryl. So this is Mike Sherels. Did I say it right? Sherels. Oh, Sherels.
Yeah,
No,
no worries.
you can't change an old dog. So we're going to put his video on, and then once the video is ended, Mike's going to talk you through a little bit of his journey. Okay?
I was 290 pounds. I really enjoyed food, obviously. Food has always been something in my life that I've enjoyed. So you're going to take the back side of the spoon and push it around like that.
Yeah,
Eating is a very social thing. And here in America, we have so many holidays that center around food and what you're going to be eating, and eating family dinners as a part of a culture. It's very important. Emily said, they had to remove your entire small intestine and you may never eat again. After they had removed my small bowel, they didn't reconnect what I had left. So half or a third of my large intestine is gone. My entire small bowel is gone. My digestive tract ended at my stomach. And then I had a loose piece of colon floating around. One morning, a new doctor came. She kind of sat at the foot of my bed and listened to them tell her about me. And she looked at me and she said, "Why is he on all this stuff? Why is he hooked up to so much stuff? Get him off that, get him off that, cut his fentanyl down in half. Let's get him up and let's get him getting back to what he's doing." And I kind of sat up and I recognized a kindred spirit. She gave me something to look forward to, or a goal to achieve, something to get towards. "70 days after emergency surgery, removing 23 feet of intestine, I'm back on the field coaching, doing what I want to do. And it felt good. It felt good to prove people wrong, to show them that I could do it. When I got reduced from 12 hours to 10 hours of TPN, it made a huge difference. We don't sleep for 12 hours. Certainly, me as a coach, I dang sure didn't sleep for 12 hours, ever. And I would have to wear my backpack then into the office the next day. So I'm at work with a TPN backpack and cords hanging out of everywhere. Well, that doesn't do much for trying to convince people that you're healthy and you can do the job. From 10 hours to 8 hours, now I don't have to hook up when I go in at all. Well, now it's really no different than like a CPAP machine. I go to sleep, I hook up, I wake up, I unhook. So mentally going from 10 hours to 8 hours was probably the largest jump. I tell people all the time, I'm a horrible patient. I'm a horrible patient. And I guarantee my doctors and nurses, they get sick of me because I'm very demanding. I'm very demanding, but I want it to be a small part of my life. I don't want it to define me in any way. And to constantly push and say, what do I need to do? What do I need to do to get down to 5? Well, we'll talk about it later. No. We're not going to talk about it later. Whatever that is, whatever that benchmark is, you do this, then you can have that. That's okay. That gives me a goal. Today, I live a fairly normal life. I got reconnected a year and a half ago. I eat now more to gain weight. I'm trying to test the limits of my body and get it to absorb more and more food. I used to do TPN 7 days a week. I'm now down to 6 days a week, and 5 is on the horizon. When I first started after the reconnect, based on how much weight I was losing and the long, complicated mathematical formula, I was absorbing 6 or 7% of what I ate. And now I am upwards of 30%. My ultimate goal would be to be completely TPN free. And some of that goal is outside of my control, but I think that there's enough eyes on it right now and the right type of people that it's a possibility. It's a long shot, but if I can't get TPN free, it's moving towards being an afterthought in my life rather than a dominating force in my life, and that's just as important.
All right, can everybody hear me? I can promise you I will not be your typical speaker. I have no medical background whatsoever. I'm a former football coach. I'm a guy, all right? I'm a guy who happens to be a bulldog. I went through some stuff, as many of you have. Some of you were born with short bowel. It runs the gamut, you guys all know. This video kind of makes me uncomfortable in this setting because I feel like I'm explaining things that you guys are all like, that's not the way it works. But my journey with short bowel is just under 4 years now. Went through an accident. I was a very, very busy professional. I was a coach. Didn't have a lot of time, and then this happened. And to know my response, my wife's response, you have to kind of know a little bit about us. We are very type A. We're both Division I athletes, very competitive, never tell me I can't do anything type of people. And when this happened, it immediately, at first there's the woe is me and all of that stuff, but our goal was to, as I said in the video, to get past it and to make it, I accept that, okay, I have short bowel. Let me have the best possible life that somebody with short bowel can possibly have. And that has been my goal. And when I say in there that my doctors and nurses probably don't like me very much. I'm dead serious. And some of my doctors are here and they do like me. I'm not a jerk. But I am very, very persistent. And I have things that I refuse to compromise on. And I force my doctors to think outside of the box and try to come up with a solution. And I'm very, very willing to help them into reaching that solution. But I know that solutions are out there. And I refuse to be told, we can't do that, or we'll do it later, or we're just not quite ready yet. And I have a hard time accepting that. And so I push people, and I push people, and I push people. And sometimes I push too far, but it's my life. And if I push too far, it's for my own benefit. And if I don't push far enough, then I might be missing something. So I know it's sometimes second nature to not want to offend people, to push and advocate for yourself or for your child or whoever it might be. But if you have something that you want to get done, that you want in life, then try to find a way to get it done. And maybe it can't be, maybe it can't, but you never know until you ask, and ask other consumers. And there's such a wealth of knowledge that people have little fixes for things, that if we just could come together and have and that's what the benefit of a great foundation like this is meeting other people who have a similar path and trying to navigate it together. I want to also address that, on the video I was at 6 days a week TPN and 5 was on the horizon. And I know I'm up here as an example of, TPN and I'm doing well and all that stuff, but it hasn't been without setbacks. I am back to 7 days of TPN a week. So it's not all sunshine and roses. It's 2 steps forward, 1 step back. But all in all, I'm happy with my progress where I am right now. And I will certainly continue to push and try new things and new drugs. And that's the best advice I can give, is try not to get discouraged. I say try because you will. You will. It's inevitable. It's hard. At times it is horrible and you feel unlucky, and it's the roller coaster. But when you have successes, or when you fight for something that you wanted, for me it was, cutting my TPN time down. What do I need to do? I can't. And there's some people out there who I'm very sensitive to. You have to wear your backpacks into the office and things like that. To me, I was a football coach. I was going into recruits' living rooms trying to convince their parents that I was going to be this son's coach and do all this stuff. And I could not do that with a backpack. I couldn't do it mentally. I mean, physically, yeah, you can walk into a house and do all that stuff, but mentally I could not do it. And met with doctors time and time again about, okay, what can we do? Even if it's just 1 or 2 days a week, what can we do to drop that down, to drop that time down? So we tried X, Y, and Z. We tried different medications, tried titrating my food so that I could absorb more different. And slowly but surely, I started to gain weight, which was what they wanted me to do. And I did everything, and we just tried. We ran the gamut, but they had to think outside the box and do a lot of different things. But eventually I was able to cut it down, and I was given a pass for if I needed to, I could go down to 8 hours for a night, which made a big deal. It made a big difference. And I think 4 hours in the grand scheme of things isn't a huge deal, but mentally it was a victory, and I hadn't had many victories, and that was very early on. And take the victories that you get and cherish them, and try to expand on them. Don't give just if something starts to work and you get to a point where it's acceptable and it's good, keep going. Keep going. All right. I don't know. I don't think I'm doing questions right now, but I think I'm speaking later. But thank you guys very much for your time. Good luck to all of you.
And we have more in the way of inspiration. I would like Hannah Jordan to join me. Here she comes. stand up here, take a bow, your video will play. Now, would you like to sit down there or up here? Whatever. Okay, good.
Lower this, I'm not that tall. Hi, my name is Hannah Jordan, and I'm from Tulsa, Oklahoma, and as you can see, I'm a competitive cyclist. But before I continue, I'd like to thank everyone in this room, from parents, clinicians, doctors, because no matter how big a role you think you have or how small a role, each and one of you have played a vital and key role in someone's life, whether you realize it or not. I think what many of us has gone through is none of us had the easiest road in life. None of us got the cards we probably thought we were supposed to get dealt, or what we thought we should have, been given, luckily, like as the AKA normal life. And most of us, we don't get the easiest life and start. And it's not about how you start, it's about how you finish. From being a very young child and sick most of my life, as I said, I kind of skipped childhood. From my heart my heart was enlarged, gut shutting down, lungs kept collapsing, brain sagging my skull, etc. I could go on, but for me, those things didn't matter. I could have let those things define me, and even I had my own moments going through all of it. And I was like, I can either sit here, I had an epiphany when I was 8 years old. I was like, I can either sit here on the couch and I can give up and I can just die and do what everyone expected me and watch the world go by. And I was like, or I can get up and I can do something with my life and not let whatever I have define me. And I made a decision that day. I didn't know what it looked like until 4 years ago when I learned how to ride a bike because I was sick most of my life. And so with the first 10 days of learning to ride a bike, I do 210 miles. My mom was so eager. She was like, she couldn't find anyone to let me ride. And she was like, she called the Olympic Training Center and she was like, do you guys know where my daughter can ride? She's 13. You're like, yeah, that really shouldn't matter. She's like, well, she's 13 and she has tubes coming out of her. They're like, oh, okay. We don't know what to do, but there's a junior camp coming up, and so we drove 13 hours to Colorado, and I learned how to ride a bike. And so within the first 2 months of learning how to ride a bike, I did my first century, which is 63 miles, which on clipless pedals, which means your feet are like locked into the bike. So if you crash, good luck. And so the very next day, I saw this bike race, and of course, me being Hannah, I bring my bike to it, even though I didn't know I was gonna race. And I was like, Mom, I wanna do that. And she's like, okay, good luck. And so, of course, it was a state championship. That medal you saw in there, that was my first race. It was 25 kids that I was competing against, and I couldn't get my feet clipped in halfway through the race. And so finally I got clipped in, and I just started going after it. And so time goes on. We go to this next camp, and I complete it. And we go to the Boulder Sports and Fitness Medicine. And when they found out, because I thought I was healed, I can get off of this. And I was devastated when I found out I couldn't, because most people's metabolism burns 50% protein, 50% carbohydrate. Mine is 95% carbohydrate and 5% protein. And I was absolutely devastated. I was like, I don't want to ride another day. I'm done with it. And my mom pulled me aside. She was like, Hannah, you've been through so much. This ain't gonna stop you, and you're too dang stubborn. She said to me, you can either let this impact your life, or you can live your life to the fullest, no matter what happens. And I think that's what's cool about every single one in this room, is that we think that we're the weakest ones in society, but actually we're quite the strongest, because no matter what we go through, we'll do anything what it takes to make your life, your kid's life, better. And I think that's what makes this school cool about this bunch of individuals. And so If I could leave one thing with you guys, is that no matter, you build the walls that you want to live in, and they only go as high or as low as you put them, and don't let anyone or anything define you just because of what you have. Thank you.
I don't know. I don't know how you all feel, but I don't think I'll get on a bike with Hannah. Our next video star cannot be with us, but he will be joining us via Skype, and we'll show his video. It's not rocket science right now, and then we'll pull him in.
The material that we're made of, well, we have a lot of stuff that the stars have. From 1 million miles away, the Earth looks totally different than what you'd ever see from a shuttle, because you don't see the whole Earth from the shuttle. You're too close to it. It gives you a philosophical or religious question about why am I here? What am I supposed to do? How important is this life to me? What I've been doing since 1978 is I've been working at Goddard Space Flight Center in Greenbelt, Maryland, as a quote-unquote rocket scientist. My primary jobs have been to get ready, prepare for mission operations for operating a spacecraft. The Hubble Space Telescope, I did that for 8 years. I did it on the Terra mission, an Earth science mission, for 2 years. And then on the Fermi, a gamma ray satellite. And I just finished my last mission, Discover, which is a space weather warning system. So that's my bread and butter and what I've been doing for a long, long time. My best memories are of working with people on these projects in getting through problems. The community's been tremendous help for me. I have a condition called short gut syndrome or short bowel syndrome. What that means is that my intestine cannot absorb enough nutrients and fluids to maintain my body weight and my body health. Well, I'm on something that is called total parenteral nutrition. I have to infuse calories via the equivalent of saline bags every night for 12 hours. It gives me the nutrients I need and the fluids I need to maintain my body weight. I have what's called a PICC line, a peripherally inserted central catheter. It's almost equivalent to an IV that you would get in a hospital if you were on medications, but the difference being that this is permanent. When I first was diagnosed with short bowel syndrome, didn't know where to go, what to do, and it turns out that there was an organization called the Oley Foundation, Oley.org. Its goal is to help people, give them information with people like myself. The two biggest things that they've done for me is, one, they're healthcare organizations, doctors, etc., who are knowledgeable about this, who are experts in this, who will help you and talk about what you need to do. The other thing is that just seeing all these other people here, you get to talk to other people, what are their problems. The question is, how do you get through this, Jack? What do you do to get through this every day? Because it does affect your life. I try to minimize a little bit, but that's maybe because I've been doing it for so long. So the first thing everybody needs is a caregiver. I couldn't do it without my wife, Carol. 44 years we've been happily married. So yeah, without it, I'm sure that I probably may not have even survived literally living. And the other thing is you just have to let it not affect your life as much as possible. You just have to minimize it. You have to have determination. So why do I get out of bed every day? Some people could just sort of give up and say, but I think it's just how much you feel about life. I'm not anything special to the world, but again, you're born, you're there. There's got to be some reason for you living. So why wouldn't I? Why wouldn't I keep on doing that? Can you hear me? Yes, I heard. Okay. So first of all, I'd like to thank my daughter Julie and her friend Wynn, who produced that video over 3 years ago. The idea was to give it to Oley and to give folks an idea of what it was like to be under TPN and to show a quasi-normal person under that condition. So I want to go back a little bit and just talk about my history, about how I got to where I am, and a little bit about what I do professionally. In 1996, I had my first colonoscopy a little over the age of 50, and they discovered a villus adenoma, which is a polyp in my colon, which it was pre-malignant, could turn into cancer. So they did a partial colon resection. This was in 96. 5 days later, I was in the emergency room with pain level of about 9 out of 10. It turns out I had small bowel obstruction where the bowel is looped or twisted. Most likely that was from scar tissue from previous surgeries that I had for other illnesses. And I just want to say, I'm not going to go into what my other illnesses are, but that is one thing that a lot of people who are on enteral feeding or parenteral feeding do have other conditions that affect their lifestyle. But again, I'm not going to talk about that. So after that first or second visit to the emergency room, and at the emergency room, all they could do basically was put an NG tube down into your stomach, which is, for those who have had that, a very unpleasant experience. And so after about 2 of those episodes, I found a gastroenterologist who prescribed Stomal, which was a narcotic, a nasal inhaler. And so I started taking that. And so when I got severe pain, I would take the narcotic via an inhaler, and felt pretty good about that. But the gastroenterologist and other medical people who were taking care of me were concerned that there might be some permanent damage and it might get masked by the fact that I didn't have the pain. So I stopped Stomal, and over a 6-year period, or an 8-year period from 96 to 2004, I went at least 35 times to the emergency room where they gave me morphine, put an NG tube down my throat, much to my chagrin. Stayed for an overnight in the hospital, got an x-ray, saw that things cleared, and then the next day went back to work. I had a couple of surgeries that tried to fix the problem, a lysis of adhesions and then a small bowel bypass. The surgeon thought there was enough bowel left, small bowel, to allow me to absorb nutrients and fluids, but unfortunately there was enteritis, and that resulted in short gut or short bowel syndrome in 2004. So in 2005, after my weight dropped about 20 pounds from 150 to 130, I got on TPN. I've been on it since then, except for some reason from 2011 to 2012, I got off of it. Don't have any idea why, but then I had to get back on. I still eat. Mike was talking about reducing his hours. I was at 12 hours. Through my care team, I'm down to 10 hours, which does make a difference. So basically, I just have the bag on at home. Early on, I wasn't very good about line care. I had 5 line infections in 3 years. One of those was very serious. I learned how to take care of the line, and that was since 2009. I have not had a line infection. As was shown in the video, I'm one of the few people. I have a single lumen PICC line. I prefer that. The reason I did was that because I had 2 tunnel catheters, Groschon's, and turns out I immediately got infections within 6 weeks of both of those. So I'm on a single lumen PICC line. Change it maybe every year, year and a half or 2, and that's usually because of a blockage. My wife and I have now been happily married 48 years. She's my primary caregiver, and without having somebody who is your caregiver and your primary advocate to deal with the hospital people, you know, I may not be here today or in the state I'm in. I have an excellent gastroenterologist who's been with me since 2004, who looks at my labs every month and calls me up when he hasn't heard from me in a while. I have to thank also my TPN team. I won't, because I won't say who they are, but they knew who they are. The pharmacy has been outstanding. The dietitian established a personal relationship. Even getting the supplies is been very important. To be very candid, my most debilitating symptom still is the big D, diarrhea. That's D-I-A-R-R-H-E-A. My sister-in-law jokes. She says that's what she's learned the most from me about being on TPN is how to spell diarrhea. That is a problem for a lot of people. It's a social problem. I've tried everything that I know of. I've seen a diarrhea special at Hopkins. And that's the one thing that out of this whole episode affects my life. I've been an aerospace engineer since '78, working for NASA. I'm still working. I retired 8 years ago, but I'm self-employed and I still work on a dark energy mission. As I said in the video, I was fortunate to work on Hubble Space Telescope for 16 years. I did travel a lot. There's talk about travel. Somebody talked about travel earlier. I was fortunate. I got to travel to the San Francisco Bay Area and to Phoenix. That was especially nice in the winter. And I just had not only my TPN shipped, but I also had my supplies, my tubing and all that. I just took my backpack and my battery and my pump. So that wasn't any problem. Let's see, what else is on personal travel. We've been to 2 trips to Africa for camera safaris. We did that in 14 and 16. Been over to Normandy, the beaches of Normandy, been over Scandinavia and all that. So basically what I've done on those trips is, because I can eat a little bit and I can survive without TPN every night, even though I do infuse 7 nights a week. I just take a few liters of saline and get through the traveling that way. So Carol and I missed being there. We just, for various reasons, couldn't be there. We weren't there last year. We're going to make sure we get there next year. We missed the folks, and I think that's about all I have to say. Thank you.
Thank you so much, Jack. We so appreciate it, and we can see Carol. If we could all wave to Carol, we see you, Carol. We do miss you, and we hope you'll be here seriously next year. Well, not here, but somewhere. Thank you so much. Is there anyone in the room who isn't inspired? Is there anyone in the room that feels like we could maybe adjust our own personal goals a little bit? Yeah, a couple of us. Yeah. just a few ordinary people getting through the day, doing what they do. So I really appreciate all three speakers for joining us and being willing to dig down and share some of those stories. I mean, going back to when you began, it is tough. It's tough. I'm surprised they managed without a few sniffles. But moving on, I'd like to share another inspiring story. We had a gentleman, an Oley member, walk into our office months ago, and with a proposal that he hike the long trail and in our area, and with hopes of raising money to support Oley programs. His name is Al McKay, and honestly, it was the first time I set eyes on him. We had no idea he was coming, and with some work from our development director, and we all kind of pitched in and made this happen. And we have a slide, several slides, right? There's Al. And I have to say, right now, it's kind of like, where's Waldo? Where is he? Because he's on the hike right now. He started out with a goal. He set a goal for himself of raising $5,000 before we were able to publish anything in the newsletter about the hike. He said, we better change the article because I've already raised over $12,000. And at the time we left the office for Chicago, he was up over 13,000. So, gosh only knows. He's very connected. He's very connected to some people, some strong people. And basically, above and beyond raising money to cover Oley programs, he wanted awareness that tube feeders can move on, move ahead with their lives and set goals and live full lives. So we wished him well. We promised to celebrate his journey when he returns and takes a shower. And not a minute before the shower. So we're very excited about that, and we just can't wait. So I think what we've learned over the last day and a half is you don't need to know everything, because some of the presentations, if not a lot of the presentations, probably went, shoo. Someone mentioned yesterday, or last night actually, that someone mentioned, and I believe it was you, Dr. Carroll, that they had no idea or they did know what what is it, the blood clotter? Alteplase. They knew what it was, but they kind of suspected that other people may not have caught on. So I thought about that, and what I'd like to say is you may leave this meeting not knowing everything and not understanding everything that was presented, but keep your program or your app closed, because you will know, am I beeping? Because you will know who knows it if you keep your program or the app loaded on your phone. So I think that's good. And we'd really appreciate it if you go home. We hope that you incorporate some of what you learned into your discussions with your physicians. And please do not implement anything that you've learned here without discussing them with your physician. That gets us in big trouble. So you can't even imagine the trouble. Oh, but they told us at Oley. I wanted to share what exciting news that I got some figures for us. People have been wandering around, how many people are here? Our attendance, and this is just an approximate, our attendance is 441 people, confirmed. The breakdown is 179 consumers and family members, which is good, great. We're going neck and neck with the clinician and members of industry. That number is 177. So you know what you have to do. Let's get going. And we have 41 children with us. And if you dropped them, put that sign down. And if, no, this is really important, and I don't care if you flash, I'm done. No, good. 41 children, if they're in our care, pick them up. And really exciting for us is we have 142 first-timers. Now, would you stand up, please, if you're here for the first time? Really? I mean, this is really... This is really wonderful, and I hope it's not the first time of one time we see you. And we do so appreciate people who step up and react to our appeals for first-time travel grants, because I think the first-time attendance here does spark some thoughts and connects you with some people who you wouldn't have met otherwise, so we're really happy about that. And another impressive number is 46 walk-ins. So, I mean, in spite of trying to get people to register ahead of time, and I know you all share, would the walk-ins stand up? No, probably not. So, we had 43 live streams. Now, that's a number no one shared with me. That's very, very well.
I just wanted to say that the recordings will be available, right?
Recordings will be available online, and if we have permission to post slides, they'll be up there. So there's many reasons to visit www.oley.org. Yes, good. So I believe that concludes our morning session. There's been the cancellation of the coping breakouts due to an emergency, but our speaker, Tiffany Taft, has agreed to do at least one webinar, if not two, and watch for notifications from Oley, or visit oley.org. Yes.